Hi, everybody. My name is Laura Varnum. I am a clinical pharmacist specialist at UMass Memorial Medical Center in Worcester, Massachusetts, and I will be presenting today about pregnancy, lactation, and preconception planning in IBD patients. I have no financial disclosures. My objectives for this morning will be to describe preconception recommendations for female patients, identify which IBD medications are safe to use through pregnancy and breastfeeding, to summarize current literature for the use of small molecules in pregnancy and breastfeeding, and to summarize immunization recommendations for children exposed to IBD medications in utero. And also, before I get started, just for simplicity's sake, I want to open up now and say, I acknowledge that there are people that can conceive and are pregnant that do not identify as female, but are, for the simplicity of today's presentation, I'm going to talk about, I'll use like the word mom or woman or, just things like that, but acknowledge that I do know that that doesn't apply to all pregnant people. So we'll start off with preconception planning. So the general recommendations is that providers should discuss preconception planning to all of their IBD patients of childbearing potential. Ideally, this conception planning would happen at least 6 months prior to attempting conception. And this is really because you want the patient's disease to be in remission for 3 to 6 months prior to conceiving. And this really gets down to, you'll hear this over and over again, like healthy mom, healthy baby. The healthier mom is, the better the outcomes are for her pregnancy and for her baby. All IBD pregnancies are considered to be high risk. So it is recommended to refer patients to maternal fetal medicine if it's available at your health center. And it's also recommended that they should start a prenatal multivitamin that contains folic acid at least 1 month pre-conception. There was a study published back a decade ago in 2016 in Clinical Gastroenterology and Hepatology that looked at the importance of preconception planning. And really, I think this speaks a lot to how pharmacists can improve work in preconception planning, because one of the biggest things they found statistical significance is the amount of patients who continue to be adherent to their IBD medications during pregnancy. So here's that area there. And really, I think we've all had patients that they send us a message or we see them in a follow-up visit and they're like, hey, I'm pregnant and I haven't taken my medication since I found out. And we're like, why? And it's like, well, I didn't know I could or that I was supposed to. So, really, again, we want to make sure our patients are compliant with their medications. They continue their medications throughout their pregnancies as long as it's safe to do so. And again, better outcomes in with the pregnancies. So back to how I've stated that all IBD pregnancies are considered high risk. This is because there have been found to be 5 different areas that are have increased rates with all IBD pregnancies. So those include inadequate gestational weight gain, so like low birth weight, moms developing gestational diabetes. This is connected a lot with corticosteroid use in pregnancy, but just overall, there has been shown to be an increased risk for gestational diabetes during IBD pregnancy. Patients have already an increased risk for developing severe eclampsia and preeclampsia, as well as blood clots. And the pregnancies are also at an increased risk for preterm delivery, which can lead to NICU stay. So when counseling patients, you want to consider what medications that they're on and if they need to be stopped prior to conceiving. So patients that are taking aminosalicylates, azathioprine or 6-MP, and any of our biologics, there's no need to stop. But if they are taking methotrexate as like a combination therapy, you want to stop that at least 4 weeks prior to conception. And then for our S1Ps, etrasimod should be 1 to 2 weeks before conception, ozanimod at least 3 months before conception. And then for our JAK inhibitors, it's a minimum of 4 weeks prior to conception. Again, this is all ideally. So next, we'll go into pregnancy. And so similar table to kind of start us off. It's very similar to the preconception planning table. So if a drug could be continued, didn't have to be stopped or held during preconception planning, then it's safe to be continued during pregnancy. Of course, we know methotrexate is a big no-no. And at this time, it is recommended that for all of our small molecules, the S1Ps and JAK inhibitors, that those should be avoided during pregnancy. And I really liked this graphic that was included in the consensus data guidelines. So when like there's the placenta, so the way that the medication, the monoclonal antibodies get transferred to the fetus through the placenta is utilizing the FcRn transport. And really, this FcRn transporter molecule is how any antibody, so it can any sort of immune system antibody crosses from the maternal blood into the fetal blood. But with small molecules, there's not a lot understood about it, but it's believed that it's passive diffusion. That passive diffusion can occur as soon as the placenta is formed, so in the first trimester, whereas this FcRn protein for the monoclonal antibodies doesn't start working until the second and third trimesters. So our monoclonal antibodies can transfer into the fetal bloodstream later on in the pregnancy. When looking at corticosteroid use in pregnancy, women on corticosteroids have been found to be more likely to develop gestational diabetes. Again, I think that's connected to the increased rate, the risk, the side effect profile of increasing the patient's blood sugar. Studies have also shown an increased risk of oral cleft palates in babies that are exposed to corticosteroids use in utero. Use is also associated with an increased risk for preterm birth, low birth weight, small gestational age, intrauterine growth restriction, and NICU admission. The use of steroids does mirror disease activity. So obviously, if a mom is flaring during pregnancy, you have to start her on corticosteroids to get her disease under control. So it's really difficult to determine the true cause of these outcomes and like why the babies are smaller and need NICU stays and born earlier. Because if the disease is more active, then it's been shown to have poor pregnancy outcomes. So it's really hard to kind of determine like the chicken or the egg. And in the P&O registry, they did show that late corticosteroid use is associated with serious infections at 9 and 12 months of age of the infant. And then even though thiopurines, so azathioprine and 6-MP, are safe to continue treatment throughout pregnancy if the patient is stable on those medications, it is now not recommended to initiate a thiopurine treatment during pregnancy. And this is due to the increased risk for pancreatitis and bone marrow suppression. If a patient is on thiopurines during pregnancy, you want to make sure that to monitor the patient for intrahepatic cholestasis of pregnancy. You want to check their LFTs each trimester. And then once during pregnancy, it's recommended to measure their metabolite levels. And if the metabolite levels are elevated, then you want to make sure you can consider split dosing, so BID dosing instead of daily dosing to help reduce those metabolite levels. Looking at our small molecules, so S1P receptors are involved in early fetal development. So they're involved in the formation of the heart, the blood vessels, the brain, along with the limbs. And so in animal studies, ozanimod was linked to fetal death and severe malformations in rabbits. And animal studies for etrasimod also showed fetal death and severe malformations. It is important to note that the ozanimod studies, it was human doses where they did see these risks. So at this time, the FDA has said that it's relatively contraindicated to use these medications in pregnancy. There have been studies that have looked at retrospective analysis of the clinical trials of both ozanimod and etrasimod. And so in the ozanimod retrospective analysis, there was a total of 78 pregnancies in the clinical trials that had outcomes comparable to the general population. But it is important that to know that in the clinical trials, if a pregnancy was confirmed, either ozanimod had to be discontinued and they had to withdraw from the trial, or they had to elect to terminate the pregnancy in order to remain on the medication. So the average duration of exposure was only 5 to 6 weeks. So the safety later in pregnancy still remains unclear. And this was throughout all of the ozanimod clinical trials. So this also included relapsing multiple sclerosis. Then looking at etrasimod data, so again, same sort of thing, retrospective analysis of the clinical trials. So all exposures were limited to the first trimester. And the drug, so again, the drug was DC'd in any female patient who became pregnant. But again, they, similar outcomes in the pregnancies. Moving on to our JAK inhibitors. So in the animal studies, tofacitinib caused death and teratogenic effects in rabbits. However, these doses were over 6 times higher than the standard, the high 10 milligram BID dose that we use in humans. And then for upadacitinib, the administration led to musculoskeletal and cardiovascular malformation when given to pregnant rats and rabbits, and this was human doses. So again, the FDA states that these are relatively contraindicated in pregnancy. Similarly to RS1Ps, the JAK inhibitors, they also released a retrospective analysis of their clinical trials. So looking at tofacitinib, all exposures except for 2 were limited to the first trimester. 4 ulcerative colitis patients had exposure from 60 to 90 days of gestation. And again, outcomes were consistent with the general population. But as you can see, looking at the graph, of a minority of the patients had ulcerative colitis, because again, this was all of the clinical trials across tofacitinib's indications. There have been a few case reports published since tofacitinib came to market about exposure during pregnancy. So first, these 2 came out of the University of Calgary up in Canada. And so the first, a 28-year-old female with UC, was started on tofa at 15 weeks gestation in combination with ustekinumab, Q4, and mesalamine due to ongoing flare despite being on corticosteroids and being reintroduced with ustekinumab. And fortunately, healthy baby born at 39 weeks, good weight, no NICU stay, no birth defects. But the tofa was discontinued at birth because the mom wanted to breastfeed. And then again, a 30-year-old female with UC conceived 5 months into being on high-dose tofa. It was decreased down to 5 milligrams twice daily at 23 weeks gestation. Baby was born at 37 weeks due to maternal hypertension, but had no NICU stay, was good birth weight and no birth defects. And this mom elected to continue treatment while breastfeeding, and the baby received the rotavirus vaccine on schedule and remained well through the 12-month follow-up period. Then there were 2 other case reports that came out of the Dumbo Spanish registry, which is a registry for pregnant women with IBD. And as a former pregnant woman, I think it's pretty terrible that they named this the Dumbo registry, because I know I was super self-conscious of my pregnant body, so I wouldn't want to be compared to an elephant. But anyway, there was this registry had 2 case reports. So a 24-year-old female with UC conceived while taking tofa 10 milligrams BID, but discontinued upon learning of the pregnancy and was transitioned over to adalimumab. So fetus was only exposed for about 5 weeks, but healthy baby boy via vaginal delivery at full term. And then another 39-year-old female with UC conceived while on tofa, did decrease down to 5 BID, but then had to discontinue the tofacitinib at 18 weeks due to a UC flare. This baby was born early due to premature rupture of membranes. They were tiny and spent 25 days in the NICU, and they were also born with polydactyly on the first finger of the left hand. But this polydactyly is one of the most common birth defects found. So again, it's really hard to say if this polydactyly was due to the tofacitinib or if this would have occurred regardless of the treatment that mom was taking. Looking at our upadacitinib outcomes, so again, retrospective analysis of the clinical trials, including post-marketing data, all exposures were limited to the first trimester except for 2, and in those 2, the babies had no congenital anomalies at birth. And there were 48 cases with known outcomes reported in the post-market data. 2 of them had ulcerative colitis, none had Crohn's. That resulted in 22 live births without birth defects, which again, rates consistent with with the general population. And then case reports for UPA exposure during pregnancy. So there was a 33-year-old female with UC who was started on high-dose UPA at 28 weeks due to disease activity. And she was able to get off of her corticosteroids by 31 weeks. Baby was born 4 weeks later at 35 weeks due to premature labor. Born on the smaller side, but never had to stay in the NICU. And the UPA was DC'd at delivery due to mom wanting to breastfeed, and they ended up restarting infliximab, which is what she was on prior to having to start the UPA. And then there was a 34-year-old female with UC who was started on UPA at 28 weeks due to disease activity and medication history. Baby boy born full term, good weight, no NICU stay, and it was discontinued at delivery because mom wanted to breastfeed, and mom was started on golimumab for her UC. And then this was an interesting case report that I found that was actually published in a nutrition journal. So it was a 34-year-old female with Crohn's disease and chronic intestinal failure due to short bowel syndrome who was on chronic parenteral nutrition, who conceived while she was taking high-dose UPA. She required IV hydration 3 times a week throughout her pregnancy, but healthy baby, born full term, good weight. It did not, because this case report was published in a journal that focuses more on nutrition, it didn't talk about what the mom, like what happened with the UPA during the pregnancy and what was happened at delivery. But I still thought it was interesting that like we have this, really sick patient who has a really complicated medical history that again had a positive birth outcome. There are a few general recommendations for all pregnancies in IBD. One is the recommendation to initiate baby aspirin daily by 12 to 16 weeks gestation. This is to decrease the risk of severe preterm preeclampsia. And it has been shown that this daily aspirin use does not increase the risk of mom flaring during pregnancy. And then for all pregnant patients, you want to make sure you check their micronutrients, so folate, iron, B12, and vitamin D levels for deficiencies, and then replete as needed, as if we were for any of our other IBD patients. And then once baby's born, if mom wishes to breastfeed, breastfeeding is recommended. Again, the consensus guidelines say that there's no reason that mom can't breastfeed. It's not associated with an increased risk of IBD exacerbation. And it's really easy to remember, if the medication was safe for pregnancy, it's safe for breastfeeding. In breastfed infants exposed to biologics, there have been no differences seen in growth, development, or infection rate. In 3 infants exposed to TOFA in pregnancy and breastfeeding, normal development through 3.5, 12, and 14 months respectively, excuse me. So again, I'm a visual person, so that same for the monoclonal antibody transfer, it's that same FcRn protein transport protein that is required to transfer the monoclonal antibodies across from the maternal bloodstream into the breast tissue and into the breast milk. And then similarly, the small molecule transfer continues to happen through passive diffusion. And then, as a mom, we all care about, there not being any risk to our babies. And I think that's that's definitely a conversation that's come up in my practice, talking to women that want to get pregnant. They're like, is there any risk to my kid as they're growing up? So it has been shown that children exposed to biologics or thiopurines in utero achieved all their growth milestones at the same rate as unexposed children. And the Danish Health Registry showed no increased risk of autism or ADHD with thiopurine exposure. There has been no correlation with IBD treatment exposure and adverse long-term health outcomes. And infants and children should receive all recommended inactive vaccines, regardless of medication exposure in utero or breastfeeding. And this includes the live rotavirus vaccine is safe to receive on schedule in biologic exposed infants. Before this consensus guideline came out, the recommendation was that the rotavirus vaccine be held for the first 6 months. but now there's been enough published data out there that says the infants are not at an increased risk for having adverse effects from receiving the live rotavirus vaccine on schedule. Live vaccines are okay after 1 month of age if the baby is exposed to JAK inhibitors or S1Ps while in utero. And then the BCG vaccine should be avoided in the first 6 months. The BCG vaccine for tuberculosis is not on the United States general immunization recommendations, but because this was a global consensus, there are other countries that routinely vaccinate with the BCG vaccine. So in case you're ever talking to someone from another country, you do want to make sure that that is not given in the first 6 months. And then I didn't want the men to feel left out, but they get the easy way out, and there has been shown to be no adverse outcomes for any medication for males with IBD. So they can be on biologics, they can be on methotrexate, they can be on thiopurines, they can be on small molecules. And at this point, there has been no significant association in changes to male fertility, as well as adverse pregnancy outcomes for their partner or the fetus. And then just to wrap it up, I really liked this summary table that is included in the consensus guidelines. It has, it kind of summarizes all of the information that I went throughout the presentation regarding the different medication classes and when it's safe or not safe to have patients on them. And with that, I am all set, and here are my references. And I'll stop sharing the screen.
Thank you so much, Dr. Burnham. This is a great initial presentation to start the symposium off, especially given the updates that we've had in the past year. So very much appreciate you sharing your expertise and being the first presenter. As everyone's, I know, still waking up, getting their caffeine in them. If you all can just look at the bottom bar, your question and answer section option, click into that, and you can enter your questions now for Laura. And I got a couple questions to start off here. So first off, small molecules and pregnancy. I think that's a big pregnancy and lactation, big question, big area of curiosity right now. Multi-part question, like with the information you've reviewed with your experience, how do you approach the situation where someone is considering a small molecule, but also either considering pregnancy in the distant future, maybe in the closer, nearer future, pending remission, or perhaps already pregnant. So I guess those kind of three: distant, ideally sooner, or current pregnancy.
Yeah, I actually recently had this come up with a patient who's she's in her early 20s. So fortunately, not fortunately, but childbearing age, like she's not thinking about pregnancy for a little while. And the general recommendation from my attending is that as long as they're not considering, you want to give the JAK inhibitor or the small molecule like a year. And then, we could always stop it. And then as long as if the patient had a positive response, especially to something like a JAK inhibitor, then you can always go back to it because you're not worried about the same immunogenicity that you are with the monoclonal antibodies. So I think, so distant future, I think we like to give it, in our practice, we give it we want to have the patient on it for about a year, make sure they're in remission, and then we can always step back or, pivot therapy at that point. If it's going to be less than a year, then I think we need to have a discussion about wanting them to be in their best healthy place before conceiving. Because like I said, healthy mom, healthy baby, the better the pregnancy outcomes are going to be. If they are already pregnant, I guess I haven't come across that in my own practice, fortunately. But I think it would be like a risk versus benefits discussion with the patient as far as, here's the data that we have. If we need to, we want mom to like we want everything to be in the best place that it can be. But I guess fortunately, I haven't had somebody on a small molecule conceive. We have considered starting a JAK inhibitor in the second trimester for a really sick patient, but she actually ended up doing really well and turning a corner. So we haven't had to start that at that point. So I hope that
Wonderful.
kind of answers your multi-part.
Yeah, absolutely. Yeah, thanks for like taking it multi-part, always trickier. A question coming in that kind of flips this. In your practice, if a patient is actually currently on the JAK inhibitor and well controlled, what is your next step in that situation when they're currently on it, and maybe considering or becomes pregnant? I guess we kind of already went through the becoming pregnant, but on a JAK inhibitor, doing well, now wants to become pregnant.
Yeah, I think at this point we would just discuss that, you laying out the data that we have as far as, we know that the medication is going to cross into the fetal bloodstream as soon as there's the placenta. And that these medications are like the receptors are involved in fetal development. So we're not totally sure, and we're never really going to truly know, like, we're never going to, like, there's never going to be a clinical trial that truly looks at this, but we can lay out the information that we have and explain, look at their medication history. Maybe there's another biologic that they haven't tried. Like maybe we went right from an anti-TNF to a JAK inhibitor because they were flaring and they were doing really poorly. We can switch them over to like an IL-23 inhibitor, which is very safe in pregnancy. So, if possible, it would be great to be able to switch them, but I think it would really be a risk benefit conversation with the patient, with the attending, with maternal fetal medicine to really get, the best plan in place for
Huh,
mom.
thank you. What about thiopurines, kind of changing gears a little bit here? I think what you presented is showing like maintaining on the thiopurine is okay, but it certainly doesn't without any risk, especially kind of with the considerations of checking metabolites and potentially split dosing. How do you approach that for someone who is on a thiopurine and either wishing to become pregnant or is pregnant? Do you just kind of like continue that without that, or are you assessing for kind of continuation versus de-escalation of that thiopurine in that moment?
Yeah, I think it also depends on if the patient's been on a thiopurine as monotherapy for like a really long time, they've had disease for a really long time, they've been on it, that's just what they've been put on. I think if that's the only thing that they're on and they're in remission, don't rock the boat. Just keep, check their labs, check their LFTs, check their CBC, close monitoring in that aspect. If the thiopurine is being used in combination with an anti-TNF medication, then I think I would be more likely to discontinue it as long as, her disease is in remission and, everything is going well. And then you can always consider stopping it for the pregnancy. And then if for some reason she needed it postpartum added back on as combination therapy, then it could be added on at that point.
Wonderful. I think, these conversations, as I think about them, can be very sensitive sometimes for patients, both pregnancy and, people have the history of a disease flare, and that's, very anxiety inducing of, okay, a change or not a change, but the potential of a flare with pregnancy. What tools do you or your team use to kind of facilitate these conversations, or kind of approach it with like how do you kind of approach these conversations, especially as they're a little bit more sensitive?
Yeah, I think so I have an interesting approach where I also am a patient. So I, especially with my female patients who want to become pregnant, I do disclose like I have Crohn's disease, I have two kids. Kind of sharing my own story because I think that changes the dynamic of the conversation, but not everybody has that ability to do that. So I think, I discuss about the piano registry and I discuss about, these consensus guidelines. My coworker actually was having a conversation. She's breastfeeding, and our attending wants her to start on a thiopurine in combination with infliximab, and she was like super hesitant. And so I like pulled up I was preparing this presentation, and I pulled up the consensus guidelines, and I was like, Sarah, like talk to her about this. And she was still really hesitant, but I think if you can present them with a lot of literature, and then but at the same time understand that like they're they're not worried just about themselves, they're worried about their kid and their baby. And as a mom, I can fully understand putting them before yourself. um so I think it's really just having empathy and compassion. And I think any patient or any provider, any pharmacist that's talking to a patient, whether it's a female or a male pharmacist, like even if it's a male pharmacist, yeah, you'll never be pregnant, but maybe you have kids or you have nieces and nephews, like you have a sibling that went through it, like something. There's always a way that you can like relate to it and can kind of see their point of view. And I think that's super important. And I think I think sharing their perspective and point of view is important as a pharmacist, no matter what conversation you're having with them.
Yeah. Yeah. I appreciate like the balance and like that human connection is so, so important. And your empathic approach, I appreciate your openness to share with the group here today, but also with patients, your journey. And the dual approach also showing that data. I think we have such a wealth of information in pregnancy and lactation that's not found in all disease states and
Mm-hmm.
all, medicine. So I love that dual approach to connect to the human, but also show the evidence. And
Yeah.
and it sounds like you actually like pulled it up to show a patient, which is pretty cool.
Yeah, or if I can't pull it up, at least like, have a discussion about like, these are huge, like worldwide accepted, consensus
Hmm.
guidelines and things like
Yeah,
that.
which is amazing. Very amazing. Wonderful. All right. Well, thank you so much
Thank
for
you.
your presentation this morning. Next, we get to learn from an innovation presentation about the implementation of a geriatric-focused longevity clinic embedded within an IBD service.
Right. We'll just go ahead and share my screen here. Alrighty. So good morning, everyone. My name is Sarah Guelfi. I'm the IBD clinical pharmacist at UC San Francisco. And just like Michelle introduced, I will be presenting on our new longevity clinic that we have embedded within our IBD clinic here at UCSF. I do not have any financial relationships or conflicts of interest to disclose, but I do want to recognize two physicians that I work with, Dr. Kendall Beck and Dr. Anu Madhavan, who started our clinic last June. And I do want to acknowledge that Dr. Beck has presented on geriatrics and IBD and the overall structure of our clinic before. All right, so I want to go ahead and get started by talking about IBD in older adults and just kind of introduce everyone to this population. So as we know, IBD has a multimodal onset. So there's the early onset, age is 15 to 30, but there's also a late onset that we see in patients of 40 to 60 years old. And about 15% of all IBD diagnoses are made in the elderly, and their prevalence is growing. So we anticipate by 2030 that adults 60 years and older will actually represent a third of the population of patients with IBD. And yet, given that there's this large growing population, actually a lot of the literature that we have about our older adults in IBD is very lacking. Talking about how their disease is a little bit different. So there's additional challenges and complications for patients who are older with IBD, such as variable disease outcomes. There's a wide range of differential diagnoses that we have to consider. They may be more vulnerable to the complications of immunosuppression, particularly infections. They're more likely to become homebound. They have higher rates of hospitalization. They actually have lower use of immunosuppressants. So there's a lot of things that we have to consider that we may not be needing to think about for our younger patients with IBD. And some of those things that we need to consider are geriatric symptoms or syndromes in IBD. So frailty is a big one. 18% of all patients with IBD will exhibit frailty, and that number is a quarter of all patients once they're 90 and older. Multimorbidity, almost 14% of patients with IBD will have a CCI score of 3 or more. Polypharmacy is huge with all of our patients in IBD. And this is what the literature represents, but I would say even a higher percentage of our patients than just 85% who are 60 years and older will have 5 or more medications. Our older patients will also have more likely to have lower lean muscle mass and strength. They have increased risk of dementia, fatigue, fecal incontinence, falls, and social isolation. So these are all additional factors that we need to consider when providing treatment for our patients. And as pharmacists, I would be remiss if I didn't touch a little bit extra on polypharmacy. So like I mentioned, this is common for all patients with IBD. And we know that polypharmacy has a negative impact on both drug adherence and increased risk of drug-drug interactions. Also, patients with polypharmacy are more likely to be filling at more than one pharmacy, and this can lead to increased confusion, drug interactions, non-adherence, and also just overall provider and family burden. A lot of confusion about medications overall. So the AGA, when we're talking about guideline recommendations for our elderly patients with IBD, there's a lot of different recommendations that they provide. One is, we should be managing their comorbidities or considering their comorbidities, facilitating vaccines, try to use the treatments with the lowest possible infection risk. Also consider all of those additional geriatric syndromes, the frailty, their functional status, and things like that. And what this is really getting at, one provider alone can't do this. So what we really need is a multidisciplinary approach to be managing properly these patients. So we introduce our longevity clinic. So at UCSF, we created a service within our IBD clinic. These are our 2 physicians, our geriatrician, Dr. Anand Madhavan, and then one of our gastroenterologists, Dr. Kendall Beck. And this is just some call outs in our local news that we were proud of about our new clinic. The focus of our longevity clinic, we're looking at the 5 M's of geriatric care for GI patients. So the geriatrician, what she is focusing a lot on is mind, so depression, mentation. We have our multi-complexity. So again, looking at those geriatric syndromes, their multimorbidity, what matters most. So talking about advanced care planning, their goals of their care, and also mobility. So assessing falls, frailty, and function. And then where I come in and I'm doing a lot of the assessment with their medications. Those other 4 things are already a lot to tackle in one visit. So I will focus a lot on the patient's medications and make sure that we can get a fully focused visit just to talk about their medications and some other things, which I will go over. So this is the overall structure of our longevity clinic at UCSF. So a patient, anyone 65 or older in our IBD clinic will be identified and they will be referred to the longevity clinic. It starts with a visit with me first. So the pharmacist will always start. That way we can get a good medication history and get a good introduction to the patient and prep them for the future visits. They will then be seen by a dietitian that we have at UCSF who specializes in IBD, and then they will have the visit with our geriatrician. The pharmacist and the dietitian visit are one-time consults, and then the visit with the geriatrician, she will actually follow up with them as needed, so she will determine if they need 3-month, 6-month, or annual follow-ups with her. And then, of course, today we will be focusing on the clinical pharmacist portion of this clinic. So these are the key components that I focus on during my visit. So like I've mentioned before, very heavy on medication management. If there's one thing I'm going to focus on in my visit, and I do have an hour, fortunately, with these patients, it's going to be really, really in-depth medication history. I'll also go over vaccine screenings, lab screenings, and then we'll also do an IBD symptom assessment for them. So going into medication management, these are the 5 pillars that I use for a really, really strong medication history. So, and like I mentioned, this is one of the most important parts because as we may know, our older patients are seen by a lot of different specialties. They have a lot of different providers and their medication lists can be very overwhelming or incorrect and just a lot of conflict seen in there. So I will do a very thorough, detailed medication review, and I will let the patient know this. I'll tell them, we're going to go slowly through this. We're going to talk about the exact doses, how many tablets, what time of day that you take things. So we go very in depth. I'll also do a DDI screening and analysis and go over that with the patient as well. Also big focus on deprescribing. So see what things can I identify, maybe like some low-hanging fruit that we can help reduce the number of medications for the patient. We'll also talk about medication adherence. So I am a huge proponent for pill boxes. It is the one thing that I feel like is a really easy maybe non-glamorous fix, but that can really help improve patients' medication adherence. Sometimes we do have to get a little bit creative, but that's something else that I will discuss with the patients. And then last but not least, we will talk about supplement reviews. Supplements are definitely going to be included in their medication list. And sometimes these can be excessive. Sometimes maybe they're needed. Sometimes they're not. So I'll be sure to go over this as well. For vaccine recommendations, these are the ones that I'm focusing on, very routine. Some call outs that I just wanted to make for the pneumococcal vaccine. Sometimes the recommendations can be a little bit confusing. Do you recommend, is it after 1 year or 5 years after their last dose? There's a lot of different things to consider. So I just wanted to call out that the CDC has this site called Pneumovax Rec Advisor, where you can just plug and chug the patient's information, their age, the vaccines they've received in the past for pneumococcal, and it'll tell you what the recommendation is. So sometimes that can be a nice quick way to get the most updated recommendation. For the shingles vaccine, I just wanted to call out that for patients at an increased infection risk, we can actually do the second dose as soon as 1 month after the first dose. For the general population, it's 2 to 6 months, but for our increased infection risk, we can do it as soon as 1 month. I will also always counsel on the common side effects of the shingles vaccine just to prepare my patients so that they're aware and know what to anticipate just in case they do have some of those flu-like symptoms afterwards. And then RSV, of course, in our immunocompromised increased infection risk patients, we can give it as young as 50 years old. Tdap, very routine. And then hepatitis B, we will look at their antibodies and recommend boosters if appropriate. Looking at lab monitoring, so on the left is what we have our routine, drug monitoring for patients who are on biologics or small molecules. And we'll do these CBC and LFTs at least every 6 months, if not more frequent. And then annual TB, and then routine hepatitis B serologies every few years, just to make sure they have maintained their immune response. And then on the right, these are additional labs that I will get for patients, specifically for our longevity clinic. So all of these panels, there are areas that our elderly patients may be deficient in, specifically with IBD because of malabsorption. So if patients haven't had this in the last 6 to 12 months, I will also go ahead and order these during my visit. That way they can have time to get the lab and then assess them with the geriatrician once they have that follow-up. So I wanted to introduce a case here, and this is actually a pretty typical patient for our longevity clinic. So TH is a 72-year-old male with ulcerative colitis. He is on infliximab. He does the Zinfentra injections every 2 weeks, and he was referred to the UCSF longevity clinic. He has a past medical history of migraine, sleep apnea, GERD, chronic pain, stage 3 CKD, arthritis, hyperlipidemia, hypertension, and type 2 diabetes. He has a local PCP outside of UCSF. And prior to the clinic, he was seen by endocrinology for concern of adrenal insufficiency. And so he was started on a slow hydrocortisone taper, and he just had completed the taper the day before my visit with him. Today, at the start of our visit, he reports, some of his main concerns are that when he's having a good stretch, he'll have 5 bowel movements a day. However, recently he's been having 7 to 10 bowel movements daily that are occasionally bloody, and he has increased urgency. He also reports, unrelated to his IBD, he noticed that his blood sugars are lower and he feels that he's having more hypoglycemic events. And he also notices that recently he's just had a lot more nausea in the morning. So when I dig into this patient, this is the medication list that I'm provided with at first. This is what's the most recent in our chart. Some immediate things that come to my mind when I'm looking for, through the med list, are they still on this vitamin D once weekly? Probably not. I see gabapentin, I see melatonin, tramadol, zolpidem. So I'm like, okay, there's a lot of sedating agents here. Are they still taking ibuprofen? I, hope not, or at least maybe it's minimal. I know he just told me he finished this hydrocortisone taper. So some things that we're thinking about, I also see a PPI chronically. So things that I'm already flagging that I want to dig into. So here are some updates that we made. So he did in fact finish his once weekly vitamin D. Gabapentin is a little bit more detailed. So he'll take it like 100 milligram as needed for neuropathy, and then he'll actually do 300 milligrams as needed for sleep if the melatonin isn't sufficient. We got rid of some things. We adjusted his losartan to make it accurate. I found out for omeprazole, he has a history of GERD, but he's actually never tried stopping a PPI. He started a course years ago, and then he just continued it long term, which is pretty common with our adult patients. I also found out he recently started Ribelsis because his PCP noticed that he had higher blood sugars, and this correlated with the time with his hydrocortisone taper. So he was started on Ribelsis. We also talked about, his sumatriptan for his migraines. He rarely needs it. Same with tramadol. He very, very infrequently uses it. And then his zolpidem, he only takes for international flights, so maybe once a year. So this is his new updated med list, a little more clean, a little more accurate, but there's still some things that I want to go over with him. So with him, we talked about the omeprazole, discussed a slow taper. Has he ever tried tapering it down? Discussed the importance of a taper. I don't want him to just immediately stop it. Talked about the long-term risk of PPI use, particularly with bone health. So we discussed for him a taper going down, again, a very slow taper just to see what he can tolerate. And if he can't tolerate it, that's okay, but we at least want to make sure we're getting him on the lowest risk thing that works for him. If that happens to be omeprazole 40 milligrams daily, that's okay, but we just want to make sure that's what's needed. Also thinking about the Ribelsis, this is probably contributing to his new nausea. He didn't know much about GLP-1s. Also, there's a lot of changes with his steroids, right? Now he's not on steroids, but has this medication. GLP-1s aren't known to cause hypoglycemia on their own, but still this can be something, there was a lot of med changes going on and not much adjustment once his steroids came down. And then also the tramadol, like, is this still needed? Why does he even still have this active prescription if he's only using it a couple times a year and he has all these other sleep agents on board? So just things that we're trying to do to minimize risk. And then this is a DDI chart that I will usually have in my notes just like this, where I'll document all of the current drug interactions, but most importantly, I'll talk about the context of these interactions in the comments, right? So we see multiple sedating agents, but he does not use these all the time. Tramadol and zolpidem are only a couple times a year. We talked about, does he really need the tramadol still? Same, he's on bupropion and tramadol. This can increase seizure threshold, lower seizure threshold. He doesn't have a history of seizures, which we talked about. Again, very low use of the tramadol. He's on multiple sedating agents. The melatonin is more regular. The zolpidem is not. And then same, the serotonergic risk with sumatriptan and tramadol. Both of these are very rarely used. So even though when you would plug these into an interaction checker, it looks like there's a lot going on. But with context, maybe they're a little bit more controlled and also continues to identify things that we can maybe take off for him. Looking at his vaccine history, so I saw this patient back in October of 2025. So this was his immunization history. At the time, he was just due for an updated COVID and flu vaccine in the fall. And then it had also been 5 years since his last PPSV 23 vaccine. So he was eligible for the updated pneumococcal vaccine. And then looking at his labs, on the left is the labs that he had up to date. On the right were the labs that I ordered. So it had been more than 6 months since his last CBC, and since he is on infliximab on a biologic, I want to get an updated one. I want to get an updated TB and hepatitis B serologies. We actually didn't get his surface antibody levels last time. And then I do want to, again, like I mentioned, all of these health maintenance labs for him to see what his levels are. They can help with supplementation or maybe reducing supplements. So just to check that for him. So here was my final assessment and plan for this patient. So we created a slow PPI taper for him. I counseled him on the side effects of GLP-1s, talking a little bit about how to recognize and treat hypoglycemia. I know this isn't really IBD related, but just, general things that we're all aware of. Talked to him about considering to pause the GLP-1. We discussed the need to pause tramadol. We talked about the immunizations and labs that we ordered for him. And then lastly, talking about his IBD. So if you remember from the beginning, he was having worsening symptoms, even though he was very adherent to his Infentra. I saw he didn't have a follow-up scheduled. So I connected with the MD and let them know that we might need to be escalating therapy because he might be failing Infentra therapy. And then our update on him is that a few months later, when I checked back, he had paused the Ribelsis, noticed a lot of improvement with his nausea. So he's working with his PCP on restarting that if needed. He was able to decrease his omeprazole from 40 milligrams daily to 10 milligrams daily. So not able to completely get off the PPI, but definitely reduce risk. He had completed his PCV20 vaccination. And then after I had communicated with the MD, they did a repeat flex sig that showed Mayo 3 disease despite being on the Zinfentra. So we actually escalated his therapy to Rinvoq, and he had seen a lot of improvements in his UC symptoms. And then lastly, I just wanted to give a call out. I created this presentation before this data was presented, but it was presented at DDW earlier this month. And it's just a report of kind of the structure of our clinic and all of the results that we found. I can tell you from the pharmacy perspective, all of our patients had polypharmacy. So a big thing that we want to be focusing on their medication list as well. And then here are my references. And I will go ahead and stop sharing.
Thank you so much, Dr. Guelfi. This is amazing work as we kind of continue with special populations this morning. You make a really good point at the beginning of the growing number of older adults with IBD. And while pregnancy, we have a wealth of information growing, as you point out, not as much, and certainly some unique complexities in this older adult population. So again, I welcome everyone. Pop questions in the Q&A for the few-minute Q&A we have. I have a whole slew of questions. I'm so curious and interested in this. Maybe first kind of logistics of your clinic for anyone who's like, oh yeah, we've been thinking about starting this or wanting to start this. Could you speak a little bit to kind of, are these appointments in person? Are they virtual? Is it just the one time versus consideration for like a follow-up pharmacist visit down the road? Are you billing right now, or kind of how is the position supported? Lots of questions there, but if you could just kind of speak into some of the logistics.
Those are fantastic questions and things that I'm very happy to talk about. So to start with how I do my visits. So I do all of my visits via telehealth right now. That just tends to be the most convenient for patients. We are located in San Francisco, not the easiest to get to, park and all that stuff. So it helps with a lot of access for patients. Our geriatrician will offer, or she does patients in person. And in fact, some of our providers prefer that their patients, when they go to see the geriatrician, that they actually go in person. So there's some providers that want all of their patients to see her in person. For me, because we're just doing a lot of review, no physical assessments, everything is able to be done virtually. And a lot of times it's just easier for the patients. They can be at home with their medications, have their pill bottles in front of them, things like that. And then for your question about follow-up,
Like how?
so, yeah. So we start with a one time, but I will definitely, I communicate with the geriatrician and the dietitian a lot. So if I have a really complex patient and there's things I want to, of course, they're going to review my note before their visit. But if there's things I want to kind of clue them in on, I will let them know, hey, maybe discuss this. I've had a patient where I'm like, we didn't really get time to fully dive into it, but maybe we want to start an SSRI for them or things like that. They'll do the same thing back to me. So if they see them and they're like, oh, they've had more medication changes, they're a little bit more confused. Can we just do another visit? I'm like, absolutely. So we start as a one time, but if needed, we just communicate back and forth and I will see them again if needed for any medication changes. In terms of billing, this is something that's very new for my service. And I mean, within like the last month. So things that, via regulations, like what we're allowed to do. So I am allowed to bill for, and I will say this might be honestly a better question for my supervisor because I'm working with her a lot on like the logistics and the legality of billing, right? I actually, if they're Medicare, I can't remember if there's certain things we can or cannot do, but for my general visits, I am able to bill for like facility fees and things like that. Because there are some days where, I'm in the office, but I'm still doing virtual visits. We're working on exploring ways that we can increase, our billable services and what we can do with pharmacists. I know there's a lot of like legislation that's involved with that as well, but definitely a really hot topic for us right now. But as far as right now, it's just for facility fees and things like that.
Hot topic for all of us, I think, as we are navigating that. Another question here for virtual, are they telephone, video? Is it a mix?
I prefer video. So we will schedule everything as video. And then if the patient, communicates that they actually prefer telephone, they have difficulties with the video visit, then we can switch to telephone. I think a lot of times just for that personal connection, again, sometimes they're physically showing me the pill bottles. So I think just to kind of develop that rapport and just to kind of understand their body language a little bit more, video is a bit better.
Definitely gives you that extra layer of
Yes,
information.
yes.
Um, Another question that came in, is it only a geriatrician that is involved, or is GI involved in the clinic as well?
It's only a geriatrician. So there will be the gastroenterologists that are referring them, so they have to identify them. I will say at the beginning it was a little bit unique. So when we opened our clinic or opened our service, what we did was we sent out a mass message to anyone who was seen by our IBD clinic who was 65 or older. So sometimes we identified these patients who maybe hadn't been seen in a while, they weren't directly referred from a physician visit. Now that we're a little more up and running, usually it's they're seen by their gastroenterologist and they identify, hey, do you want to be seen by our longevity clinic as well if you're over 65? Myself and the dietitian, we specialize in IBD. The geriatrician does not specialize in IBD. We just partner with her from the Department of Geriatrics. And we make that known to the patients. You know, she is not a specialist in the IBD, but she's a specialist in all things care for older adults.
Really cool collaboration, like
Yeah.
across everyone's different area of expertise. I love that. Question, how is your pharmacist visit different when you're seeing non-geriatric patients with respect to med review and actionable items?
Yes. A lot of times, I think just when we have younger patients, they just tend to have more simple medication lists. A lot of my visits, and this may be similar for a lot of people here, you know, sometimes I'm focusing on new medication education. So sometimes there's just different priorities. I will always like to go down our medication list and at least make sure that we have everything that's accurate, but my priorities change. So sometimes I won't necessarily have time to go fully in depth about their drug interactions because I need to focus on talking to them about how we're going to start their Tremfya, or focusing on, you know, I'll do injection training. So I'm like, we're here to talk about you doing your Skyrizi injection, and that's like the only thing on their mind, and sometimes that takes up the whole time. Whereas the priorities change a little bit for my geriatrician visit, where I'm fully focused. Like the main thing for the visit is med list. Sometimes I have patients really complex medication lists. We don't even get to vaccines or labs because it truly takes that long to go through their medications. So I won't even, you know, talk about their IBD. That's the most important thing. That way I can then have that med list ready to go and hand it off to the geriatricians. And then I'll let her know, you know, we didn't have time to talk about this, but at least this is, and, you know, I can say, you know, these are my concerns. This is what we need to add, remove. Whereas in a typical visit, I'm definitely going to be doing a med rec, but depending on the time and priorities, and just generally, there's going to be less need for DDI assessment and deprescribing and things like that. But of course, if we have time and those are big things that I identify, I can do that as well. Priorities are just a little bit different.
Thank you. Thank you for the work you're doing, for sharing that with all of us. There are a couple more questions in the Q&A, so if you can just go, if you're able to write answers there, and we will
Absolutely.
continue our special populations. And now we get to learn about updates in pediatric IBD.
All right. Sorry about that, everyone. I'm having a hard time finding the unmute button just now. Hi, everyone. My name is David Sito, and today we're going to be discussing the rapidly evolving landscape of pediatric IBD. As a pharmacist involved with the pediatric IBD program at Phoenix Children's, I've seen firsthand how pediatric IBD management has really changed and shifted over the years, especially with the ongoing updates to practice guidelines and the introduction of new advanced therapies. Overall, today I'll be focusing on recent publications from the past year or two, and there's actually quite a bit to cover. So before I begin, I don't have any conflicts of interest to disclose. These are our learning objectives. Our goal today is really threefold. First is to identify management hurdles, break down the 2025 updates to UC guidelines, and then look at the clinical data supporting advanced therapies in the pediatric IBD population. Here are the abbreviations referenced throughout this slide deck. And to start with an introduction, the incidence of pediatric IBD is increasing, representing about 10 to 25% of patients with IBD. Depending on which resource you're looking at, these numbers might vary a bit. Pediatric IBD isn't really just adult IBD in smaller patients. We actually see more extensive disease and unique challenges like pharmacokinetic variability with medications, growth failure, and associated complications with this population. Moreover, we have a subset recognized as very early onset IBD, also referred to as VEO IBD, which affects kids under 6 years of age, often has a monogenic cause, making our traditional one-size-fit-all approaches less effective or guideline-directed therapies less applicable. Despite the continued introduction of advanced therapies for IBD, treatment options remain limited for pediatric patients, and we often have to reach for off-label medications or even borrow ideas from our adult counterparts for the management of more severe or refractory disease. So now let's take a look at a timeline showcasing some of the FDA approvals for advanced therapies in IBD. This chart here doesn't have all the updates or some of the new approvals seen in adult populations. And I do recognize the text may be small, but let's focus on the colors here where the green items represent medications with FDA approvals for pediatrics. So you can see we don't have many. The first advanced therapy approved for pediatric use was infliximab for Crohn's disease back in 2006 and for ulcerative colitis in 2011. Then adalimumab was approved for Crohn's disease in 2014, and it wasn't until 2021 that it got approval for ulcerative colitis. Not pictured here is the recent approval for ustekinumab, which got approval for pediatric Crohn's disease actually within the past month. The lack of FDA approvals make it really challenging for us practicing in pediatrics to reach for other advanced therapies outside the ones that are already approved. Even a medication like vedolizumab, which has been around for over a decade and is often used in pediatrics, does not have approval. And we still encounter issues with like insurance and approvals and the outpatient setting with a medication that's been widely used. As for guidelines, we rely heavily on the European guidelines. The Crohn's disease guidelines favor a top-down approach and haven't really been updated since 2020, so we won't touch much on this today. The pediatric UC guidelines were actually updated this past year, and even with a 7-year gap between the last publication, the foundational concepts of pediatric UC management remains consistent across both guidelines, where they continue to use a step-up approach. So this figure summarizes the 2025 ambulatory care updates. We'll start with the 5 ASAs, but move very quickly to advanced therapies compared to previous guidelines. Steroids are still recommended for moderate to severe disease, but the duration of therapy that they recommend in these guidelines have been shortened from 10 weeks to 7 weeks. So my understanding is that many centers actually still use even a more faster approach whenever possible. Despite this step-up approach, there's also many considerations for using infliximab for induction of remission as well. So these update guidelines also formally integrate small molecules like the JAK inhibitors into the management algorithm for both induction and for maintenance of remission, which we'll see here. So the maintenance of remission side of the algorithm really highlights the preference for a step-up approach and step down whenever possible. The major update here is the consideration of off-label therapies that were actually not previously described in the older guidelines. So to summarize this, starting with like oral 5-ASAs or rectal therapies remains unchanged from the previous recommendations. Corticosteroids can be used for moderate to severe disease, but they really highlighted the need for shorter courses. Anti-TNFs, alphas, remain the first line for advanced therapy, but the use of vedolizumab, IL-12/23, IL-23 inhibitors, JAK inhibitors, S1P receptor agonists now get a mention in the guidelines. Dual therapy is also described for consideration and has been practiced by many institutions, but this isn't really something that we'll elaborate on today. Just recognize that it is an option in practice. So now I want to move on to the acute severe colitis guideline updates. These guidelines were addressed in the part 2 section of these updated guidelines, and they really highlight on the complexities of inpatient care and recognize rescue therapies beyond steroids and infliximab should be considered. Considering how acute severe colitis is considered a medical emergency, we continuously rely on the pediatric ulcerative colitis activity index scores, the PUCAI scores, and move much quicker throughout the algorithm. So if a patient doesn't respond to IV steroids by day 3, we act on it with rescue therapy, usually with infliximab, or another agent to really avoid the need for surgery. This is a huge contrast to previous practice where surgery is actually considered much earlier, mainly due to the limited medications that were out there for pediatrics. So considering how many or a handful of patients presenting with acute severe colitis may already be on infliximab, the second line therapy section here may end up being a different type of medication. For instance, one of these medications described down here as used for rescue therapy. But the specific agent to choose remains unclear. Selection can be based on medication-related side effects, patient-specific factors, the time for onset of medication needed, what was the patient's steroid response, and even immunologic workup plays into a large role with these patients. These guidelines don't spell out which specific medication to reach for. It's more like, hey, we know these agents exist. Please consider them and just really leave it at that. And this really results in a lot of variable practices between IBD centers, pushing each center to really develop their own pathways and guidance for the use of these medications. I would also like to note that these updated guidelines also put emphasis on weaning and stopping steroids as soon as possible. So similar to the ambulatory care updates, the acute care updates also has the same recommendations to do much quicker taper or even no taper if steroids are used for less than 10 days. Yeah. So the other updates to these guidelines is the therapeutic drug monitoring section. So these guidelines recommend proactive monitoring for most of these patients, and it's almost non-negotiable. So proactive therapeutic drug monitoring results in remission rates pretty much almost double compared to reactive monitoring. With pharmacokinetic variability in pediatrics, this approach really helps us optimize the dose early on and for us to avoid antibody-driven failures. This in turn keeps our patients in remission longer. Our institution has actually implemented this practice for all our patients on anti-TNF alphas before starting their maintenance dose, so we can really optimize both the dose and frequency early on, or even switch therapies to gain a better disease control early on to avoid those like associated complications that we see in pediatrics. In the upcoming slides, I want to review each class of advanced therapy and new publications supporting their use in pediatric IBD population. I'm going to skip over the anti-TNF alphas. These agents have been around for a while, and I don't really have any major updates to report at this time. I'll also be skipping over specific details on vedolizumab publications and data for the sake of time. The main update with vedolizumab was really the updated publication of the VedoKid study in 2025, which was a multi-center prospective study involving both Crohn's disease and UC patients. This study really just confirmed many of the findings that we already knew from retrospective studies and smaller studies that we've seen with vedolizumab in pediatrics. Additionally, we learn more about the pharmacokinetics of this medication, and dosing in pediatrics has really shifted from like a 6 mg per kg per dose weight-based dose to a 10 mg per kg weight-based dose. But with that out of the way, I want to get into more of some of the newer advanced therapies, starting with a review of the IL-12/23 inhibitors, also referred to as the anti-P40 agents in the guidelines. Ustekinumab is the one we use in practice, and as previously mentioned, we now have official pediatric labeling for these medications. So we expect to see more of a push with ustekinumab to incorporate it more into our management and clinical practice. The Crohn's disease data really originated from the Unity Junior trial this past year. And it really shows the clinical response rates over 90% by week 8, which is similar to the findings that reported in the Unistor trial that was originally published back in 2024. So ustekinumab is really a vital option for those who have failed in anti-TNF alpha. Data for ulcerative colitis in pediatrics is still ongoing, and we do have some limited, our data right now is really limited to retrospective reviews. Even this retrospective data for UC is similar for the trials that we've seen for Crohn's disease, suggesting that remission can be achieved in about half the patients. Clinical response data was actually not reported in this retrospective study, though. So the next set of medications I want to go over and discuss would be the IL-23 inhibitors. These medications would include risankizumab, mirikizumab, and gosokimab. Risankizumab is the first IL-23 inhibitor marketed for IBD, and it's perhaps that's the reason why it's most used in pediatric centers. We actually adapted this at our center several years ago for refractory cases when it was first released. And here we see that risankizumab can have a positive impact on both the clinical and radiologic remission in pediatric patients. But unfortunately, we're lacking the robust data that we saw in the adult trials. The original trials on adults, such as the Advance and Motivate trials, I believe, included patients as young as 16 years of age. So that kind of gave us some reassurance that these may be appropriate for pediatric patients or at least or adolescent pediatric patients. I would also want to note that I do recognize the sequence trial recently came out, or along with some of the other IL-23 inhibitor studies that may suggest superiority over or IL-12/23s like ustekinumab. But these adult data really haven't trickled down to our pediatric population yet. And with the FDA approval for ustekinumab for Crohn's disease, justifying the use of an IL-23 may become even more challenging as time goes by. But we'll see what happens over time, and especially if these other IL-23 medications seek, or especially if these other medications seek FDA approval for pediatric indications. Mirikizumab is showing quite a lot of promise through phase 2 clinical trials in pediatrics. The investigators here reported that by week 12, almost 70% of patients achieved clinical response, and almost 40% achieved clinical remission, and just over 50% achieved endoscopic remission. Moreover, almost 40% achieved steroid-free clinical remission for at least 12 weeks leading up to week 52. So even with these positive findings, the sample size and outcomes such as clinical response and clinical remission is somewhat lagging behind ustekinumab in the pediatric population. Though we also need to keep in mind that this study is limited to a phase 2 study, and the study designs were slightly different. In a single center prospective trial, this was done in Japan, looking at just pediatric patients. The investigators found similar findings to those of the phase 2 trials. They also reported the median time to clinical remission was about 10 weeks with a range of 4 to 16 weeks. So these early studies really show promise for mirikizumab for the use in pediatric IBD. Here is a summary of the ongoing trials for the IL-23 inhibitors I was really able to locate. As you can see, all three medications have ongoing studies for both Crohn's disease and ulcerative colitis supported by their respective pharmaceutical companies. I would actually expect more to come in the near future once more data is reported out. But I think this really highlights how the landscape of pediatric IBD management is shifting much quicker than we have expected. Next, I want to move on to the small molecules that are used. So many JAK inhibitor literature in pediatrics is really just limited to retrospective reviews right now. They're also limited to patients with UC who have failed at least one advanced therapy, with infliximab being the most common one. So here we're looking at tofacitinib. Leder and colleagues conducted a multi-center retrospective study with a little over 100 patients or children with a median age of 12.8 years. This actually represents the largest pediatric IBD study with tofacitinib to date. Responses were defined as a pool chi-score less than 10 or a greater than 20% decrease. They also reported that 16% of patients achieved steroid-free clinical remission by week 8, and that number really only increased to 23% by week 24. An additional 30% achieved clinical response by week 8. So while we did hope to see better numbers of tofacitinib, these studies do still suggest that tofacitinib remains an option for a pediatric population. Our experience has also been mixed, with most success seen really in our VEO IBD patients. Ryan and colleagues conducted a single center retrospective study over 52 weeks. I recognize this study is a bit older, published in 2023, but I really wanted to use this as a reference point, despite its different study design and smaller sample size. They found that a little over 50% of patients actually achieved clinical remission by week 16, but this included patients on dual therapy. Further breakdown shows that 60% of patients, which really isn't much, it was like 3 out of 5 patients on tofacitinib monotherapy achieved clinical remission. So this study here highlights the need for even more robust pediatric studies to really support the role of our advanced therapies. For this slide, I want to focus our attention specifically on upadacitinib, as we have some more recent real-world multi-center data highlighting its efficacy in our pediatric patients. The first study here looked at a younger cohort of 100 patients, ages 8 to 15 years of age. The vast majority of these patients so 90 out of 100 had ulcerative colitis, with the remaining 10 had IBD unclassified. The key takeaway here is the rapid onset of this medication. By week 8, 84% of these patients achieved clinical response, and over half achieved steroid-free clinical remission. The second study here focuses on an older adolescent demographic with an average age of about 15.8 years. This study also looked at a large number of patients, with 100 patients in its cohort with refractory Crohn's disease. So unlike the tofacitinib studies, upadacitinib has more data for Crohn's disease patients. The study found that by week 8, 75% achieved clinical remission. And just like the first study, about 56% achieved steroid-free clinical remission. And additionally, 52% of these patients achieved clinical remission without the need for exclusive enteral nutrition. Together, I think these two studies really reinforce the idea that upadacitinib is proving to be a highly effective, fast-acting option for pediatric and adolescent patients for managing both UC and Crohn's disease. Continuing our look at upadacitinib, this study highlights 2 additional studies that further supports its use. This time looking at single-center retrospective data. The first study here is a recent 2025 study. This looked at a smaller cohort of 20 patients ranging from ages 9 to 20 years of age, with a mix of Crohn's disease, UC, and IBD unclassified. The response rates here were impressive. 90% actually achieved clinical remission by week 8 for UC and IBD unclassified, and by week 12 for Crohn's disease. Furthermore, 75% achieved steroid-free clinical remission by following induction, and 65% maintained that remission at week 24. It's also worth noting that 8 patients who underwent endoscopic evaluation, 7 of those showed response. And then the second study here is a 2024 paper by Spencer and colleagues. They looked at a cohort of about 20 adolescent patients, ages 12 to 17 years, with a fairly even split between Crohn's disease and ulcerative colitis. Once again, we see strong efficacy. 75% of these patients achieved steroid-free clinical remission by week 12. This study also noted an 80% rate of CRP normalization by week 12, indicating excellent control of systemic inflammation. So even though these studies are smaller single-center cohorts, they do continue to support the multi-center data that we just saw. We're consistently seeing high rates of clinical response, steroid-free remission, and objective measures of healing with upadacitinib in the younger population. Given these results, upadacitinib may be considered over tofacitinib, but these studies didn't really quite make it to the updated UC guidelines in the most recent publication, which again highlights a fast-paced change to therapeutic approaches with pediatric UC, and the guidelines were left vague. There's also pediatric clinical trials surrounding upadacitinib, so that's something else for us to look forward to in the near future. Ruxolitinib is another JAK inhibitor, and unlike previous therapies we discussed, it's important to note right up front that ruxolitinib is not included in the pediatric IBD guidelines or even discussed in many of the articles with IBD management. But it has carved out a very specific niche in our treatment landscape. So right now, ruxolitinib is primarily utilized as a targeted therapy for patients with VEO IBD. So the data is still emerging, but the results we are seeing in a specific population is really highly encouraging. A 2020 report by Rudra and colleagues looked at VO-IBD patients who were started on ruxolitinib as targeted therapy. They reported rapid clinical improvement within 1 week, specifically noting reductions in fevers and stool frequency. Um, this suggests that a quick onset this medication has a quick onset similar to other JAK inhibitors. And we've actually seen success with this medication in collaboration with our immunologists, given the increasing number of children diagnosed with VO-IBD with monogenic causes. Finally, we have the S1P receptor agonist. The two main examples you'll likely hear in this category would be ozanimod and etrasimod, which are probably even new for the adult market. The most important takeaway for our practice today is that the data for the use of these medications in pediatric IBD is very limited. There's not really much published out there, and so the landscape is really actively evolving. There's also ongoing clinical trials evaluating both of these drugs in the younger populations. So these studies here are critical because they are designed to determine not only the safety and efficacy profiles, but also specific pharmacokinetics in these pediatric groups. Pediatric centers I know have really explored using these off-label as well. So perhaps we'll start seeing some new retrospective reviews or case series before the publication of these phase 2 and 3 studies. So in summary, the gaps in pediatric IBD are closing, but our management remains complex. Regulatory barriers in approving medications for pediatric use contributes to the complex and challenging nature of pediatric IBD. Guidelines have been updated to include the discussion and the role of non-FDA approved therapies, but specific details remain lacking as clinical trials are ongoing. While we're moving in the right step forward, we should still recognize that a lot of these medications used in adult IBD may be options for pediatrics in the near future. Literature for these advanced therapies in pediatrics is really emerging at a much rapid pace than what we're used to compared to the past. So it's really an exciting time for us to see these medications studied. Here are my references. And that concludes.
Dive into some questions. Thank you so much, Dr. Cito. This is wonderful. I feel like I practice in the adult space, but every time at pediatrics, there's like so much more happening. Obviously, never quite fast enough, but these are some really wonderful updates to hear about. Some questions coming in for you. At Phoenix Children's, is UPA restricted at all, or do you require a failure of tofacitinib first? Kind of how do you manage that JAK selection?
We're actually very lenient with our criteria here, and we did that intentionally. So no, they do not have to fail tofacitinib first. They can jump straight to upadacitinib. That's actually what our preferred agent is based on a lot of the more recent publications. I would say the only times we really reach for tofacitinib if insurance is very persistent that they must trial tofacitinib first. So I would say that's one of the reasons. The second reason would be if we're collaborating with our immunologists and we identify the monogenic cause and tofacitinib appears to be the more reasonable option, we will pursue that route as well. But even like historically, what we've done was restrict tofacitinib to those like who can't swallow pills. But even with the new liquid formulation of upadacitinib, we've been able to get it approved for pediatric IBD patients despite not having that pediatric labeling. So we have that option available to us.
Very cool. On the same topic, but just a little bit more broadly, do you have good success with getting the off-label IBD meds approved for pediatrics, or do you have any tips on how to approach that?
Oh,
I know it's
I
a
don't know
loaded
if I have any
question.
good tips. But we do have success. We have more success with the JAK inhibitors compared to some of the other agents. So I would say we haven't, like any patient we want to start on JAK inhibitor, we've been able to do peer-to-peers and medical necessities to really get it started. What's helped us a lot is a lot of these patients get admitted for acute severe colitis. We start them inpatient and we have like very patient-specific criteria that we submit to our payers that really supports the use of these medications. So that really helps streamline the approval process. I would say we've been running into a lot of issues with the IL-12/23 inhibitors versus the IL-23s, and we actually foresee more issues coming in the near future with this new approval for ustekinumab in pediatrics. A lot of our physicians do try to favor the IL-23s like risankizumab based on like the recent adult data, but I would say like we've been really pushing in the corner and having to start with ustekinumab in a lot of these patients. So we're really in the area of trying to reevaluate how we're going to approach this. And Arizona Medicaid is not on our side right now either. So
That was another question on my mind of like, how do you balance the Ustin IL-23 with the approval, but efficacy data? Thanks for sharing that. All right, some more questions. For patients who are on methotrexate and infliximab, what kind of level drop do you expect when discontinuing methotrexate?
we actually don't routinely use immunomodulators in our practice or at least our center. So I don't think we have a very specific levels that we're looking at. And when I talk to like other pediatric IBD centers too, it seems like the practice is also very variable too. So unfortunately, I
Hard to
don't
answer.
have much to comment on that, given the differences in practice styles, even within our providers and even within other centers.
That's a-okay, and I think we can all relate to that with different topics. What about TB labs? Do you repeat those regularly, annually in the peds population, or how do you monitor?
Yeah, for TB, we and a lot of our other our biologic related labs, we do them at least once annually.
Okay,
And we're pretty religious about getting those. It's all
that's
built into our order sets and clinic appointments too, and that's a whole other discussion.
yeah, that sounds wonderful. To automate it, that you don't have to think or accidentally forget that. Wonderful. Um, with JAK inhibitors or Rinvoq, how do you manage Shingrix for pediatric populations? And then there's kind of a follow-up question with coverage in Canada. It might be different, but for Shingrix in individuals less than 18, there's certainly coverage issues with Health Canada. So do you recommend Shingrix? Kind of what does that coverage look like? Insurance
We
coverage?
actually, so I'm gonna be honest, like at our center, we don't. So I would be curious to see what other centers are doing. Maybe that's an area for improvement with our center.
Yeah. Well, and I think, we know Shingrix is approved 18 and older, so it makes sense that
Yeah.
it's, just a different topic when we're always talking about pediatrics. I think you guys are always amazing, kind of navigating things in a very off-label space sometimes and having to get creative to really meet the patient where they're at and get the best treatment. So, there are a few more questions, David, in the Q&A, if you don't mind hopping in there and typing answers if able. And then I have the privilege to transition to the next speaker before our break. And Shannon will be speaking on the implementation of upadacitinib sample program in a pediatric academic health system. So thank you so much.
Great. Thanks so much, Michelle. I appreciate it. As she shared, I'm Shannon. I'm the ambulatory GI clinical pharmacist at Children's Hospital Colorado, and today I'll be going over the implementation of an upadacitinib sample program at Children's Hospital Colorado, which is a pediatric academic health system. I have my disclosures here, as well as my 3 objectives, and then several abbreviations that I'll be using in this slide deck going forward. So I want to start with a quick background, kind of bringing us to a timeline of when we identified the need for this sample program. Starting back in March of 2022, upadacitinib was FDA approved for the treatment of ulcerative colitis in adults. That was the first IBD subtype, regardless of age range, that upadacitinib was on the market for. It was about 6 months after that that we started seeing regular prescribing of upadacitinib for the treatment of pediatric IBD at CHCO. And then about 3 months after that, started seeing regular requests to use it in patients for pediatric IBD via non-formulary requests. And then 3 months after that, kind of simultaneously, we also then have upadacitinib FDA approved for the treatment of Crohn's disease in adults. And then the first sort of round of literature describing and supporting the use of upadacitinib for the treatment of pediatric IBD. So really from the time that upadacitinib was on the market for IBD at all, it took a year, or really probably less than that, to recognize that, one, this would be a medication we'd be using pretty regularly off-label in our pediatric patients for IBD, and also a medication we'd be wanting kind of quick and easy access to, in particular for very sick patients who are admitted. So get into some rationale. I think really anecdotally, this is probably data that many of us are at least a little bit familiar with, but I'm going to walk through a couple specifics. Starting on the left, this is from a meta-analysis in 2023 that evaluated the proportion of patients who achieved symptomatic remission at weeks 2, 4, and 6. And so you can see upadacitinib highlighted on the right, several other advanced therapies, and then placebo all the way on the left. And because of the methodology of this study, it was not evaluated to detect significant differences between each of the time points, nor even between therapies, but certainly numerically we can see that a high proportion of patients comparatively achieve symptomatic remission in this meta-analysis at week 2, 4, and 6 compared to other therapies, and certainly compared to placebo all the way on the left. Moving to the right, I won't go through all of these, but these are ad hoc analyses from the 2 original phase 3 clinical trials for upadacitinib in adult ulcerative colitis. In these figures, the gray line is placebo, the red line is upadacitinib, and these looked at a variety of different symptomatic outcomes. And again, I'll not go through each of these, but looking at where we start to see significant improvement with upadacitinib, I think we start to see that kind of in general around day 3, maybe day 4, even as early perhaps as day 2. And so I think this really highlights that, again, anecdotally, maybe we're aware of this, but we tend to see quick improvement, at least from a symptomatic perspective, with upadacitinib compared to placebo, and even compared to other therapies as well. So that kind of lays out the rationale for why we want quick and easy access to this in very sick patients. Some additional rationale, kind of going back to David's discussion, is that almost all of the medications we use in pediatric patients are off-label, including upadacitinib, and so for a number of reasons we see delays in care. There's actually great literature specifically describing the first part of this being the burden of prior authorizations in pediatric IBD patients. So first, I'll mention that the majority of patients or the majority of medications require prior authorization for coverage. Usually about 75% of the time we see prior auth required for an IBD advanced therapy in this population. Unfortunately, though, there's also great literature that prior auth requirement in this population delays therapy initiation by almost 2 weeks for pediatric patients. And also increases the likelihood of various poor outcomes. So IBD-related healthcare utilization and steroid dependence, which is of kind of significant and unique concern in this population. So all around, we've got delays from prior authorization and then poor outcomes associated with those delays. We also commonly see specialty pharmacy restrictions, and this is by no means unique to pediatrics, nor unique to IBD at all. But in another patient population that also heavily relies on high cost and or specialty medications, it was identified that an external or mail order specialty pharmacy may be mandated by payers almost 80% of the time. So from an efficiency perspective, best case scenario, even if there's no prior authorization required for coverage, if patients are forced to use an outside pharmacy, it will still take time for family to have that medication in hand. Also, kind of going back to more uniquely pediatric, we often see a lack of eligibility for patient assistance programs. So this includes like quick start programs or bridge programs that, because upadacitinib is off-label for pediatric IBD, oftentimes we can't use these types of programs to expedite therapy initiation the way our adult counterparts can. And then lastly, at least in the state of Colorado, there are prescription emergency supply limits. So if a patient is in the hospital receiving a medication that's on formulary and that patient is able to discharge and they need an emergency supply of a prescription medication, in the state of Colorado, the legal limit that can be dispensed is a 3-day supply. So going back to all of the other delays that we see, unfortunately, 3 days just may not be sufficient in this population. I'll kind of end this rationale by saying before the development of this program, there were some pieces, including a policy in place to support the use of some sample medications, but it only included medications used on site. So either for inpatients or for clinic administered medications, and really did not include at all sample medications that would ultimately be used at home. So given these sort of delays and challenges we often see in pediatric patients, the solution to this was using upadacitinib sample packs. I think sample medications is something we're all at least aware of, or at least that they exist. For upadacitinib specifically, these are, of course, provided free of charge directly from the manufacturer. They're not purchased from the wholesaler like other commercial medications. Available in all 3 tablet strengths, and then convenient from an emergency or an electronic medical record build perspective. They all have unique NDCs that do not overlap with the commercially available product. And typically, though not always, we are dosing upadacitinib once daily in pediatric patients. So these sample packs come with 14 tablets, so they typically provide a 14-day supply of medication. The intent with this sample program is sort of twofold. So one, to expedite initiation of therapy. These sample packs are stored in the hospital. These patients are in the hospital, so very little delay from that perspective. But also to essentially, for lack of a better term, buy us time, typically buying us 14 days to achieve authorization, which often results initially in a denial, requiring an appeal, and even the time it takes for families to actually have medication in hand. So to get this program up and running, there were several steps involved. I'll go through each of these, but spend a little bit more time on some pieces than others. But the very first step was getting the sample packs added to our formulary. These were approved for our inpatient formulary to be added to formulary in November of 2023, though it took some time to get all the pieces in place. I'll point out just quickly that patients must be naive to therapy, so these are new starts. The prior authorization request piece must have been initiated, and then patients must have either disease that's steroid refractory or be steroid intolerant. I'll take just a moment to mention here that, again, these are new start patients, so this is intended for induction therapy. So ultimately, the 2 strengths we added to formulary were the 45 milligram tablets and the 30 milligram tablets, which are the most common strengths we're using for induction in pediatric patients when using the tablets. Getting into electronic medical record configuration, we use Epic Hyperspace at CHCO. So this order panel was developed. It includes the prior authorization initiation piece, as well as the 2 strengths that we added to formulary. When the requested dose is selected, this links to 2 unique drug files. It links to an inpatient order. This generates an inpatient label, ensures that the medication generates on the MAR and can be scanned by nursing. But it also generates an outpatient drug file, basically an ambulatory prescription. We can see clearly here that this dispenses 14 tablets with no refills. Because we wanted to ensure that this would also be adjudicated essentially as a prescription, a sample pharmacy was also developed. This is not a separate pharmacy by any means. This is a separate, basically, login or department context that team members use still within Epic Hyperspace. But by having these prescriptions still adjudicate just like a normal prescription would, it ensures that the medication shows up on the med list even after discharge. As part of this pharmacy too, insurance billing is disabled, so it essentially negates the risk of insurance accidentally being billed for these sample packs, which must be provided free of charge. So the platform that we use for prescription processing at CHCO is Willow Ambulatory. It's part of Epic, but a separate platform, and so some of our inpatient team members were not familiar with with using it. And so I'll not spend a lot of time here, but education was developed that essentially walks team members through step by step exactly how to verify and dispense a prescription medication. This also included a very clear sort of algorithm of which team members are responsible for which steps in the sample process. And this just ensures that this process works well any time of day, any day of the week. Getting into policy and procedure, like I said, there were some resources and kind of pieces in place to use sample medications at CHCO before this, but fairly limited. So I just want to point out a couple pieces that are pertinent to this sample program specifically, or were specifically added to support the use of this program. First, in acquisition, at least in the state of Colorado, upadacitinib sample packs can only be obtained via a physical signature from the provider, so they must be obtained in person. This is in contrast to some other sample medications that can be all managed electronically and then delivered directly to the pharmacy just via a delivery service, but upadacitinib must be obtained in person. And so this policy now requires that samples must be transferred to the inpatient pharmacy by the end of that business day. In storage, it also requires that sample medications must be stored in the pharmacy prior to dispensing. So from here, we're already seeing that it is disallowed to store medications and sample medications in a clinic space or an office space or anywhere like that. In ordering and verification, it does include now too that sample medication specific drug files and order sets are developed as part of implementation. The goal behind this is really to just distinguish patients who receive a sample versus those who receive, for example, like a full 30-day supply, which is adjudicated through insurance, and just to make that very clear on med lists. And then lastly, in labeling and dispensing, it requires that sample meds that will be administered on site have a label that allows scanning. Also includes now that sample meds dispensed to a patient for home use must have a prescription label. I recognize that sounds quite obvious, but that second piece was new to this policy, since previously all sample medications were administered only on site by a healthcare professional. So getting into outcomes and impact of the sample program, like I mentioned, it took a couple months to get all of the pieces in place, but this program went live March 31st of 2024, and then these outcomes were gathered March 21st of this year. So I'll call that about a 2-year time frame. In those 2 years, a total of 19 patients started a sample pack, with majority of patients receiving 45 milligrams for induction and 2 patients starting 30 milligrams for induction. Only 1 patient experienced a lapse in therapy upon completion of the sample pack. So as a reminder, that means at the end of that 14-day supply, they still did not have medication in hand. The average time from prior auth submission to authorization was 5 days. But again, that is the time to authorization, not the time to actually have medication in hand. And then at the end of those 2 years, a total of 13 of the 19 patients were still on upadacitinib. So summarizing and talking a bit more about some of these outcomes, again, I think we're kind of all aware that prior auth delays initiation of therapy and is certainly a burden, but there are additional challenges and burdens in pediatric patients, specifically mainly regarding off-label use and the inability to use patient assistance programs in many cases. To combat those challenges, this sample program allows basically near immediate initiation of therapy, and in almost all cases other than 1 patient was not associated with a lapse in therapy after completing that 14-day sample pack. Additionally, and I think very importantly, most patients who utilize the sample program remained on upadacitinib long-term. And I want to highlight that specifically because I think this indicates that despite kind of the quick and easy access to these sample packs, upadacitinib was a very clinically appropriate option for most of these patients, just based on the fact that they stayed on the therapy long term. There have been various discussions regarding expanding the sample pack program, perhaps to making it available for clinic patients rather than just inpatients, and then also perhaps loosening the restriction criteria. But I'll end by saying that overall, there's been overwhelmingly positive feedback to the sample program, certainly from the inpatient medical team and families and patients, but even from pharmacy leadership as well. I think more so because the program is very clearly laid out and is very clean from a regulatory perspective, which we all appreciate. So my references are here, and otherwise, I really want to thank everyone for the time and attention. I'll stop sharing, but happy to take any questions now.
Thank you so much, Dr. Campa. This is amazing. As we've learned about kind of the updates in pediatrics from Dr. Cito, like seeing the implementation, knowing that this stuff is, tricky even in the adult space, which is much less complicated, but the creativity you guys have implored is amazing. So thanks for your work and for sharing that with us. Questions. So I think you kind of alluded to some of this. What was this process built solely for upadacitinib, or like has it been leveraged for other medications, or could it be, do you think?
Yeah, that's a great question. I think as soon as the sample program went live, it was utilized like quickly and early. And so I will mention there were other prescription or sample medications that were being dispensed as a prescription, but once this program went live, highlighted it, and I'll say there with less regular use. And so I think the go live of this program kind of highlighted the processes for some of the other sample medications, which were not totally up to snuff, for lack of a better term. And so anyways, I think with this heavy utilization of this sample program has sort of standardized across the board. This is now the process we use for all sample medications that patients will be going home with. And I think it helped that we already, at least at CHCO, had a piece in place for like use of inpatient sample medication. So the concept as a whole was not new, but certainly has helped to ease the process for other medications that are samples that have been added to formulary since then, and kind of even highlighted that that's an option and is like allowed per CHCO policy, that those samples can also be added to formulary, and there's already a process in place for that.
Cool. Thanks for taking the lead. And we know this can be kind of a little bit of a messy area logistically. So it's so cool to just build out a really solid process.
Yeah.
Another question, what barriers do you anticipate when or if moving the program to the clinic outside of inpatient? So moving that forward.
Great question. Admittedly, this came up I don't know, it did not take long for this to come up of can we use this for others? I will share, we have, I didn't include this patients in outcomes or impact, but we have used this same process for clinic patients, but it's required like a non-formulary request, which is generally still moved pretty quickly, but because it doesn't meet our kind of very specific restriction criteria. And so I think when if it is part of a clinic visit, it then becomes perhaps we might want to treat it as like a clinic administered med, even though it's obviously administered by the patient. And so I'll say one challenge that we've kind of tried to navigate is do we have patients take the first dose then in clinic? And we have in these situations just because, why not? But that's been kind of just like a personal challenge. But otherwise, I think certainly increased use would be I would expect more increased use rather than what we've seen, given that the restriction criteria has been very clear. And so I think even perhaps maybe keeping up with the supply and demand. I mean, certainly that's not been a challenge, but it could potentially become a little bit of a slippery slope. I will say, I think, obviously David alluded to this, and there are challenges with medication access in pediatric patients. I don't know that would be a challenge, though, because even for very sick admitted patients, that's already something our team is so aware of and so cognizant of. So I wouldn't necessarily see that it would be started in a patient where we anticipate, unfortunately, very, very significant delays. And then perhaps we're getting into a situation where families still don't have medication in hand after 14 days. And then, do we bring them back into a clinic visit to get a second sample pack and whatnot? I'll lastly mention there have been discussions regarding when this program went live, we actually were kind of between outpatient discharge pharmacies at CHCO, and so didn't want to loop them into the process at that time. But now we have a new one up and running, and there have been discussions of, can sample medications just be dispensed directly from our outpatient pharmacy, negate the need for a clinic visit? And at least in the state of Colorado, the language in that like in the regulatory pieces is very confusing, perhaps even like contradictory. So, and obviously that's something nobody wants to mess with. So overall, I wouldn't necessarily anticipate a lot of physical challenges, but certainly just extra pieces to think about.
All right. So as disclosures, we just don't have, we do not have any financial relationships or conflicts of interest to disclose for this presentation. All right. So what is artificial intelligence? Artificial intelligence is technology that simulates learning, human learning, reasoning, and decision making. It includes machine learning, natural language processing, and generative AI. And in healthcare, this tool can be used to analyze data, health data, supports decisions, and enables quicker responses. But of course, this is more of a supportive tool. This is not something that, and it requires oversight, so it's not something that should be an independent process. Why AI matters. So many of our IBD therapies are specialty or infusion-based. In many cases, it's infusion-based that transitions into specialty pharmacy or the self-injectable medications. The complex workflows delay therapy initiation. So that's where the AI comes in. And some of these bottlenecks include manual chart reviews that are time consuming in order to identify the clinical information that we need for things like prior authorizations and appeals. And also when submitting these, we also have to follow up with insurers. If it's outside providers' offices or other care team members in infusion facilities. But AI can help to improve the speed and consistency in which these processes go, documentation and chart review efficiency, and authorization turnaround times. So starting off with one of the main ones that we use, especially in specialty pharmacy for the self-injectable medications that are dispensed outpatient, we use AI for those prior authorizations. These prior authorization or this AI tool can extract payer required criteria directly from the electronic medical record. It pulls things like and identifies things in the chart like diagnosis, severity, prior therapies, and labs. It reduces manual chart review because there's either search functions or it identifies based on clinical criteria. And then it also shortens the time in which it takes to submit those prior authorizations. So Ochsner, we use an AI platform that extracts the payer-specific criteria directly from the EMR or the electronic medical record and submits information into CoverMyMeds. We implemented it in 2024 to assist with some of these complex processes like the prior authorization submissions. And since then, we've approached those perspectives with about 20,000 patients across the Ochsner clinics. We've gained quicker medication access in shortened timeframes for getting prescriptions in hand for those patients, especially the ones, who are severe cases that require therapy pretty quickly. So for question identification, this is kind of what an example of the tool that we use. So for instance, the prior authorization, when you are going through the clinical criteria, the AI helps to identify based on the question, and then it will pull that out of the chart and provide a rationale for that specific clinical criteria. So when you're looking at the diagnosis, it explains the diagnosis. It also adds additional information, but also identifies that information in parts of other clinical criteria. But it just makes it much faster in being able to easily identify the clinical criteria and answer those questions pretty quickly. The answer prediction. So again, here's another example of prior therapies the patients used. It's showing that AI is predicting or pulling out all of the therapies that it mentions in the chart directly related to their inflammatory bowel disease. And it will also identify, generally timeframes and things like that the patient has been on therapy. But if it can also identify if the patient, if it was mentioned in the chart, but the patient wasn't initiated on that therapy, and sometimes in certain cases, what the reasoning was behind why the patient never started the therapy. Like for instance, insurance denial. is why the patient may have not started Tremfya, even though it was discussed with the patient in the chart. For the chart review process, AI identifies the diagnosis for the patient, prior treatment failures, and objective clinical findings, and summarize these findings for you into payer-ready language, or how the payer is requesting it. And then human review just ensures the accuracy before the final submission. So that's why, the additional oversight is required to ensure that we're submitting appropriate information to the insurance so they can't come back with a denial based on incorrect information. And then this is just an example of our turnaround times for our prior authorization since initiating AI in our system. The manual workflow, generally submitting prior authorizations when we had to do manual chart reviews and things like that, and the other processes mentioned, took about 15 to 20 minutes per authorization. But since we've implemented AI, it's decreased the time to complete these authorizations by more than 50%. So there's been a significant time saving when using AI to identify these clinical criteria and being able to submit those authorizations pretty quickly. And then not only prior authorizations, but we also use AI for our appeals as well. So if the insurance does deny it based on the patient not meeting clinical criteria, we can use the AI as well to produce the appeals or assist with the appeals to submit to get that decision overturned. Manual appeal letters are time sensitive. Again, you have to search all this information from the chart to make the clinical history for the patient and the therapies that the patient's tried. And so you have to take a lot of time to do that, as well as also structure an argument why the patient should be on therapy, the intended therapy that we're trying to get approved. The AI that we're using, it drafts the letter in minutes. And of course, again, human review remains essential in ensuring accuracy when submitting the appeals as well. And then going into appeals, Taylor will discuss more about the appeal, AI and the appeal process and other uses for AI.
All right, so as Cameron alluded to, AI can really streamline how we handle letters of medical necessity following a denial letter. It can quickly draft an appeal letter by pulling in clinical rationale, guidelines, peer-reviewed data, and patient-specific details. There are programs that are being built within our EMRs to obtain this data, and there's also external programs that would require us to input that patient-specific data. This overall leads to faster turnaround times, which helps get therapies approved quicker for our patients. And most importantly, it also reduces administrative burden, allowing us to spend more time focused on patient care while still reviewing and validating that final letter. Here we have an internal time study regarding an appeal draft preparation at Ochsner Specialty Pharmacy. As many of you know, patients with inflammatory bowel disease often have complex histories and multiple comorbidities that need to be incorporated to provide a strong letter of medical necessity. Pulling all of that together can make the process time quite time intensive. On top of that, these letters are often written in the middle of a busy workday, where interruptions can further slow your progress and impact your efficiency. Over on the left, we have an average appeal draft time, which was about 45 minutes. And then over on the right, with the implementation of AI-assisted draft appealing, it decreased it significantly to about 15 minutes. So overall, this highlights a key challenge, producing high-quality comprehensive letters while balancing other demands during the workday. Here we have an example of using AI tools to draft an appeal letter outside of the EMR without the need to include protected health information in our prompt. So instead, we provide clinical details such as the IBD phenotype, distribution of disease, along with key elements of the patient's medical history, including things like drug-induced multiple sclerosis and prior IBD therapies. We also include therapy-specific details, such as the ustekinumab dosing, drug levels, and the rationale for this patient's dose optimization. By supplying this type of targeted, de-identified clinical information, the AI can then generate a strong draft that we can then review, edit, and then personalize for our patient. And then here we have the letter that was AI generated. Over on the left, it goes into the patient's past medical history that we input, their tried and failed therapies, and it mentions towards the bottom the drug levels to support that optimized ustekinumab dosing. And then over on the right, it explains that this patient is in clinical and endoscopic remission on his current regimen. And then just below that, it does list at least 2 studies to support optimized ustekinumab dosing. I also had additionally add to the prompt to include a business letterhead, which it did over on the top left. We know that gaps due to insurance barriers can lead to possible flare-ups and overall poor patient outcomes. This really shows how AI can help support us and our patients to submit these letters to insurers efficiently without losing pertinent information that will hopefully support an approval for the patient. AI is showing up in very practical ways in our daily workflows. For example, AI voice agents can check in real time prior authorization and appeal statuses, reducing the time that we spend on making phone calls out to the insurers. Chatbots and patient messaging tools can help guide our patients to the right care more efficiently. And then within the EMR, AI can help us summarize chart reviews, saving us time. And at the bottom here, we have ambient listening. Ambient AI can capture visits and then draft notes in real time, allowing us to stay focused on the patient. And I do have some examples of different programs on the slide. AI is already having a meaningful impact on both outcomes and our day-to-day operations. One of the biggest benefits is a reduction in administrative workflow, which allows us to shift more time and energy back to clinical decision-making and back to direct patient care. We're also seeing faster turnaround times for prior authorizations and submitting those letters of medical necessity, which helps us get those therapies started sooner for our patients. Ultimately, these improvements translate into better patient satisfaction and a stronger continuity of care. So while AI adds efficiency, the real value here is giving us more time to focus on what matters most, our patients. Here we have some legal and regulatory considerations. First, we must always protect patient privacy and comply with HIPAA. We should not be putting any PHI into unapproved tools from our institutions. Second, AI supports our decisions. It does not replace us. Clinical judgment still belongs to the clinician at the end of the day. Third, human oversight and documentation are essential. One example of documentation while using AI is when we use ambient listening to help us write our notes. We do add a disclaimer in the visit note indicating that it was used and that we did, in fact, obtain patient consent. So the bottom line is AI is a tool, but the accountability still remains with us and its users. From a governance standpoint, AI use in healthcare needs to be structured and have oversight. Every tool should go through a multidisciplinary review, including legal, compliance, information systems, and operational leadership, to make sure the risks are addressed. Any AI using patient data should have a formal approval process before its use. We also need a standardized approval process so that every tool is evaluated consistently for compliance, security, and its proper data use. To address these concerns, our institution does have an AI steering committee, which helps set clear policies on what's appropriate so we can use AI safely while also protecting our patients and our practices. So let's walk through a practical framework for getting started with AI within a health system. First, we identify a high impact administrative workflow. Something like prior authorizations is where we started with, where AI can save us time and reduce burden. Next, the AI program that you want to use should go through that governance review, including IS, legal, that AI steering committee to ensure it's safe, compliant, and appropriate. Then define what success looks like in terms of metrics. For example, we looked at that time study to see, is this going to be helping us reduce that administrative workflow and be able to submit prior authorizations for our patients quicker so we can measure that real impact it's going to have. From there, we piloted the tool with a small cohort. Ochsner Specialty Pharmacy is divided up into different teams like oncology, GI, dermatology, rheumatology. And so it really started within different teams first before we scaled it out more broadly. And then because we've had such great success from there, the specialty pharmacy showed us how great of a tool this is. So now we're also using it within clinics. And then our pre-certification teams within our infusion centers are also now using AI to submit pre-certifications. There's also a need for to formally train staff on the prompting and review processes and make sure this tool is used safely and effectively. And then finally, we continuously evaluate its performance, the outcomes, and accuracy so we can refine the process over time. A lot of the different programs that we use do have agents that you can submit your feedback to, and they're really good about getting back to us and kind of adjusting the program itself and tailor it to our needs. The key takeaway with this is that successful AI adoption isn't just about the tool, but we should think about it in a more structured, stepwise approach for its implementation.
And I will say, in regards to the process implementation as well, we didn't start with, we started with one process first. So we started with prior authorizations and then transitioned into appeal processes. We're also incorporating AI into additional aspects of our workflow, like being able to make the payer calls and things like that as well. So we're kind of starting with one process, ensuring that we have that completely stable and the process has is completely functional. And then once we get that and train our staff on that process, then we continue the process again with additional staff that can, with the appeals, we did the same thing and did a small population and then tested it out that way before we implemented it amongst the entire team. And this is our
And here are
references.
our references. And does anyone have any questions for us?
Oh man, thank you so much. I think this is such an important topic that everyone is talking about is integration of AI for IBD patients, but some of the burdens like you kind of talked about as well. So we do have a couple of questions coming in through the Q&A, but we also have just a whole bunch of questions, I think, for you all about this as well. So one of the first questions that kind of came up was some of the AI software is kind of like a third-party app or web page, kind of things along those lines, and it's not truly integrated with our EMR. Can you comment on the AI software you use? Is it integrated into your EMR?
Yes. So we use a platform that is integrated with Epic, and it allows us to. So when we essentially initiate a prior authorization, it sends it over to the platform, and then it also, since it's integrated with the chart, when it's going through the clinical questions and clinical criteria, it identifies those questions, and directly from the medical record. So it is a separate platform, but it is integrated with Epic. So everything that we do, we can identify in that platform the specific information that we need.
So you don't have to necessarily like upload documents to this platform, and that's how AI knows to screen. It's just automatically pulling from your EMR.
Correct.
And do you mind me asking? Sometimes, there are cases where there could be some discrepancies in the chart, like something wasn't documented properly, or kind of things like that, or maybe there's care. I don't know if it sifts through like care everywhere, or maybe outside records too. Have you seen cases where, how, like, I guess, how does it actually help resolve that discrepancy?
So I think that's where the oversight's going to come in. So when it identifies within the rationale of like the clinical criteria, sometimes it'll state conflicting information. Like, for instance, it says the patient's been on this med, but also says the patient hasn't started. So it usually will identify conflicting pieces of information. And at that point, we would use that opportunity to go through and identify, what the correct information is to submit to that. I'm not sure. I want to say if the Care Everywhere record is already updated in the chart, like it actually shows in the encounters, I believe it looks through that. But it's always worth a quick glance to ensure that it's identifying that based on what information that it's pulling from, especially based on the provider that created the visit note and things like that. So it for the most part we're still easily able to identify discrepancies when if there's conflicting information within the chart.
Yeah, absolutely. Thank you so much for that as well. And I think like you mentioned, it's always going to be key that we always review, just make sure that everything is correct, being just a really important part of this process as well. So we had two follow-up questions in terms of implementation considerations and things like that. So the first one is kind of specific getting at, when you're selecting an AI platform, because I feel like there's so many out there, are there any criteria to consider that you would recommend at this point?
I think overall, like looking at the product itself and what it can provide for you, and then also I think at the top criteria is also making sure that it does seem like a secure program. Obviously, we don't want any patient health information getting out where it doesn't need to be. I would say that's probably at the top of the list is overall not letting that, patient information get out, and then seeing what other products they may have and might be able to help in other areas as well.
And our team usually goes, so the team the AI platform, the team for that platform um, has essentially consulted with, our legal team and all of that, and they've signed the appropriate documents that are required to ensure that they have, that they're able to access patient information and make sure that it stays HIPAA compliant.
Yeah, I mean that makes total sense as well, and definitely important criteria. I think we're all just trying to keep up with AI and just better understand the governance, like you mentioned, and just integration, just some of the considerations there. So that's definitely very helpful to know. This may not be a question you can answer, so I'm still going to ask it. If you're like, hey, we don't know the detail, or that's not something we can talk about, I totally get it. I think this is becoming one of the big questions is a lot of clinics, a lot of specialties are asking for more prior authorization support. So, going to institutions, hiring FTEs, things like that. So now we're at kind of this crucial point of do we hire more FTEs for individuals to help with this, or should we invest and, partner with an AI company that maybe can help with the workflow to help streamline the approach. That way you don't have to necessarily increase FTEs, but maybe you can handle a larger volume or kind of things like that. Can you comment on maybe some of the costs of the platforms? Like, because especially with institutions that haven't really started these discussions, do you know kind of how that cost aspect looks like?
I do not personally.
Yeah, I think that we were not involved in the initial process when the AI was looked into at that.
Okay,
But
got it.
I do know that the obviously the benefit has to outweigh the cost, and they of course take that as a major consideration. So my assumption would be that the platform was a reasonably priced option, especially with the need. And I think that it's important to focus on the staff that we do have and the needs that they have, and the assistance that they need, but also there's opportunities to maybe hire additional people for oversight. So I think it would reduce the need to significantly increase, the amount of help that we would need. or FTEs, but I think that, you could still hire someone, say, for that human oversight aspect, while still really focusing on the needs of the clinical staff that you already have.
Yeah, which makes total sense as well. So going into the Q&A section, so some of the questions I came up with, this looks like a great tool to reduce turnaround time to medication approval. Can you further elaborate on the human review process? I imagine that still requires chart review by technicians and pharmacists, which may still take a good amount of time. How do you keep the efficiency of AI while maintaining a thorough human review process?
From the specialty pharmacy perspective, I know that we do, like, as we're doing the prior authorization, I still review at least the most recent clinical note. So that way you can easily identify at least the information that it's providing you is correct. Um, because usually our IBD department is very thorough with their documentation. So even if it doesn't, we're not going back over their entire history. The entire history is pretty much mentioned in all of the documentation in the most recent visit note. So, if there's, because they also put, like, in very easy to identify, like, these are the previous therapies that the patients tried, these are the current therapies that they're on. So really, I think that it's still going to require some overview just to make sure that, it's still functioning and that you're providing the correct information to the payer, but a lot less than you would generally need if you were doing the entire review process yourself. And of course, some of the questions I think are, you could do a quick reference from, if it's asking, like, what of the previous therapies the patient tried, and it gives you that rationale, we can easily just go over to the note and look and see as well that that matches up. But in most cases, um, it's much faster to just ensure that, you get the whole PA, and then you can do a quick review of the note just to ensure that everything is correct. But for the most part, I think that there's been very little instances where it's pulling up, pieces of information that are completely inaccurate.
Got it. And just kind of follow up from a different aspect that you mentioned earlier. Is your institution using the AI voice for PA and appeals follow-up?
I don't think we've implemented it, at least on the clinic side, for that just yet.
So what do you mean by AI? Like the voice
Um, it's
documentation?
it's the one where it's like the follow-up for PAs and appeals, so like contacting insurance companies
Right,
to
right.
try and obtain those.
That's actually where I think that we're headed next. They're actually reviewing that now, but it's not been rolled out to all of our teams. So I think we just have one team currently working on it at the specialty pharmacy for testing at this point.
Perfect. Definitely in the future, we would love to have you back to talk about that because I think that's the biggest pain point for us is really just we're not getting the real-time updates. The calls are taking forever. We're being transferred to the wrong departments, hung up on halfway through. So just, I think that's definitely one of the huge benefits from that standpoint as well. Some of the additional questions, what concerns or barriers did the governance stakeholders present when you were going through this process?
Um, Let me think. So I would say some of the possible concerns were, of course, making sure that it's HIPAA compliant, making sure that we're submitting the appropriate information to the payer, because of course that's the liability of the pharmacy if we're providing information that's inaccurate and the payer either requests additional information or we don't have that and we can't provide that, or things like that. So I think there were just some concerns with making sure that everything is accurate, that we're maintaining HIPAA compliance, that there's no form of data leaks and things like that. And we haven't, I think that those were major concerns that were reviewed prior to implementation. And I think that that continues to be a main view of ensuring that all of that is still true today.
Perfect. And then just one last question. We do have a couple other questions in the Q&A. So at the end, if you wouldn't mind just going through and just answering the questions, but are you able to share the name of the vendor you use?
Um,
It's Leighton Health.
All right, perfect. Yep. So that's the one I feel like I've heard most institutions kind of utilizing at this point. So definitely other institutions are uptaking. So that's really helpful to know from that standpoint. So it sounds like you all have a pretty good experience with them, or at least the process too, because you've had this now for 2, 3 years. Is that correct? That you've been utilizing this? So definitely an early adopter.
Yes.
Yeah.
Yeah.
Yep.
Oh, that's awesome. Yeah, because I think that's definitely great to hear, especially with that longer time period. I know most of our other institutions, we may only be a couple months in, so still just trying to understand workflow and just how it integrates. So, after hearing about the 2 to 3 years of your experience, definitely helpful from that standpoint as well. So with that being said, thank you so much again for this really great topic. I'm sure we're going to hear more and more about it. And we'd love to one day get a follow-up, just see just different ways you've incorporated and some of the additional aspects there. So at this point, we are going to pivot over to going over our next innovation presentations, which is really about kind of pharmacist-led monitoring strategies. And we're going to have two different groups kind of present. So I'll turn it over to Marissa.
All right. Good morning, everyone. Good afternoon to some of you. My name is Marissa Conifal. I'm the lead IBD clinical pharmacist at Stanford Healthcare. And today I'll be talking about the IBD pharmacist impact in a treat to target approach, really focusing on the implementation and analysis of our STRIDE 2 program. I have no disclosures. So our Stanford IBD program, we have 8 IBD specialized providers, physicians, and 2 APPs. We see over 3,000 IBD patient visits per year. We have 6 clinic locations and a multidisciplinary team of physicians, APPs, nurses, pharmacists, nutritionists, GI health psychologists. We really try to provide comprehensive care for our patients. Specifically with the IBD pharmacists, we work under a CPA with our physicians. It's a referral-based service, focusing really on medication education, health maintenance. We also do comprehensive medication reviews. We place orders on behalf of the IBD providers, and we have about 4 to 5 clinic days total per week with 4 IBD trained pharmacists. So many of you are familiar with the STRIDE 2 treat to target recommendations, and this was a 2021 update to the original STRIDE 1 recommendations, really providing guidance on how to best follow up with patients after they've started an advanced therapy. So the 2021 updates really provided more of a proactive approach, kind of more time-specific targets, and finally incorporated the use of biomarker normalization, in addition to the prior recommendations for clinical response, remission, and endoscopic healing. Prior to the STRIDE program at Stanford, the physician would have a patient visit, start them on a new medication, and say, okay, we'll see you in 3 months. Let us know if there's any problems. And of course, as we all know, that 3-month period, there's a lot of problems that can arise. And so we realized we need to do better for our patients. In November of 2023, one of our lead IBD physicians, Dr. Kiashian, placed a request for more pharmacist involvement, and specifically noting the STRIDE 2 guidelines on helping with the advanced therapy initiation and monitoring process. So who else was doing this? We started to look around to see if anyone else had integrated the STRIDE 2 recommendations in their practice. And me specifically, I wanted to look at where pharmacists fit in. And in a very timely manner, David from University of Chicago, our current moderator, presented his data at the 2024 symposium. And he really focused on Rinvoq and Skyrizi with ad hoc telephone calls. And it really helped to identify for us when we looked at this data, and where were the biggest time points where interventions were made. So thank you, David. And many of you have seen the STRIDE 2 infographic. And again, you can see at the bottom, we have short-term targets, intermediate targets, and long-term targets. Really initially looking at symptomatic response, kind of in the middle, are we seeing normalization of CRP and calprotectin? And of course, in the end, endoscopic healing is what we want to see. So Dr. Kiyashi and I kind of put our heads together and we said, okay, of the providers that we have that can do independent visits, such as physicians, APPs, and pharmacists, who's kind of best suited for these various steps? And also considering visit timeline, can a provider fit in 30 patients in 2 weeks from now? So who also has a little bit of flexibility in their schedule that can fit these visits in at these various time points? So ultimately, this is the plan that we came up with. The IBD pharmacist referral is what we see as kind of the ticket or the entrance into this program. And then the pharmacists have they're scheduled visits, so telephone visits at weeks 2, 4, and 6 to determine symptomatic response. At the end of those visits, we do order the biomarker visits to get the patients prepared for the week 8 APP visit, and then ultimately the MD visit at week 12. Of course, every new program requires a lot of time, development, and support. And really very early on, we recognized that the major bottleneck with this program was identifying day 0. Because at Stanford, the majority of our infusions are out of house. The majority of our prescriptions are filled in other specialty pharmacies. And so trying to get data from all of those various entities is very time consuming. And of course, asking the patient for home doses, when did you take it, right? So it just took a lot of time. So we had to identify a specific staff member, hire someone new, really simply to focus on identifying day 0, making sure the referral to pharmacy was placed, and scheduling all of the visits. Of course, we knew it was going to take more of our time from the pharmacy team. Previously, we just saw patients one time for a new medication education visit. We'd also mix in some health maintenance if it was needed for really a 1-hour kind of comprehensive visit. With this STRIDE focus, we knew we needed to find more time in our schedule and fit in more visits. And so we changed our model a little bit to have that new medication education, more of a 30-minute visit, and then also to be able to fit in those 3 follow-up visits. We developed various EPIC templates and smart phrases just to help streamline our visits. And about 1 year after the original request, which is pretty quick, I guess, but we had our soft launch just with 2 IBD providers, and then our full launch in December of 2024. So what do we cover at our visits? The new medication education visit, of course, MedRec, we really go kind of a deep dive into the medication to make sure the patient's comfortable on the moving forward with the medication, all their questions are answered. We do get baseline symptoms, so we can track that throughout the STRIDE visits. We ensure that the screening labs, of course, are ordered and completed starting a medication, but then also make sure that those baseline STRIDE labs are there, including fecal calprotectin and CRP. We do discuss various patient support programs. We want to make sure that patients can afford their medication and start to integrate them if really patients are needing medication access. We try to make all of this happen in 30 minutes. We pretty quickly realized that a lot of our time was being spent verbally assessing patient symptoms. So we did develop an IBD symptom questionnaire about 6 months into our program that was launched in July. And this questionnaire is sent to patients before the visit so they can fill this out so we can really just focus on kind of highlighted changes. At the weeks 2, 4, and 6 visit, we do discuss, are you able to get your medication? Is it arriving on time? Any issues at the infusion center? So medication access, adherence, and also, again, kind of integrating the patient assistance programs if needed. We do ask them about side effects. We help with management. We want to ensure that we're seeing symptomatic improvement, varies with the medication, but during that 6-week period as appropriate. And of course, week 6, we order those repeat biomarkers for the patient and discuss the importance of completing those. At any time point, we do escalate to the provider. They are CC'd on all of our notes, but we do reach out directly if we feel that an earlier intervention is necessary. So what are the results and impact? As of just a few days ago, we've had 527 enrollments in the program. This, of course, is not 527 patients because unfortunately we have had some treatment failures and patients re-enrolling in the program. So we do see patients again for every new medication start. As we expected, our referral volume did increase. There were some providers who weren't automatically referring their patients to us when they were starting a new medication, but of course they wanted their patients in this more comprehensive program. So we did immediately see an increase in the IBD pharmacist referrals. As expected, our visits doubled, so our visit volume definitely increased right away. And From the administrative data that we were able to capture, now having someone from the digestive health clinic team tracking these patients very closely to determine that day zero, they were also making sure that prior authorizations were being completed in a timely manner, connecting with specialty pharmacies and infusion centers, really connecting the dots and making sure that we were aware of any steps that needed, that were in the way of patients starting medications sooner. And we identified right here, you see November of 2024, when we first started capturing this data, pretty quickly, we were able to greatly reduce the time for therapy initiation from what was 3+ weeks down to really on average less than 2 weeks now. We also wanted to look at our clinical outcomes. A group of us was formed with the physicians, APPs, and some pharmacists to really determine our clinical outcomes. In December of 2025, we were able to gather 95 patients with at least 6 months of follow-up visits completed at that time point. And that cohort was matched 1-to-1 with patients pre-STRIDE program. And our findings were very promising. So within 6 months, the STRIDE 2 patients had more pharmacist visits, of course, had more physician or APP visits, were more likely to have completed at least one biomarker, including CRP and fecal calprotectin. For those treated with TNFs, we found that the drug concentration level was checked more frequently. The median time to first physician follow-up visit was shorter. We had more frequent endoscopic evaluation, more frequent therapy change for those non-responders, of course. And all of these items that we were checking, if you can kind of remember the STRIDE 2 infographic, it's really everything on that chart. So we saw an improvement every step along in the process. Of course, we want to know, are patients buying into this? Do they feel like it's an appropriate use of their time? So we developed a survey that was sent to patients when they first enrolled into the program before any visits with any of the team members. And then we also sent those same 4 questions to the patients at week 12. So after they've had a lot of those kind of initial visits at weeks 2, 4, 6, 8, 12, right? And I just wanted to point out here really, or just kind of capture those patients that strongly agree, just so you can see the shift in sentiment. And from visit frequency is appropriate, good use of my time, appropriate provider type, and really notably important that there was such a jump in patients feeling that this was very valuable to supporting their IBD care. How does it impact the providers? All 8 of the providers responded. All 8 of our physicians responded. And the majority of them here, as you can see, strongly agreed that having a pharmacist on their team helps them work at the top of their licensure, that the IBD pharmacists are making the appropriate interventions and recommendations and escalations, that it helped improve lab monitoring, helped improve medication adherence, and helped their patients reach their goals. Specifically, we asked how important are these, is pharmacist involvement in the program on your ability to manage the IBD patients? The majority said it was extremely important. And I was actually surprised and kind of happy with this second question, with the final question is, we had over half of the providers say that having the pharmacist in this program significantly improved their ability to see additional patients and to kind of better manage their clinic day. So it really is helping them see more patients and really helping to reduce their time. So in conclusion, the implementation of a treat-to-target pharmacist-centric multidisciplinary follow-up program for IBD patients starting advanced therapy resulted in faster time to first dose, earlier and more frequent follow-up visits, higher rates of both biochemical and endoscopic assessment, earlier therapy adjustments for those non-responders, notable patient and provider satisfaction. I almost wish I had more time there was a free text at the week 12 visit to show all the amazing comments from our patients that really are super appreciative of the time in this program, and positive impact on physician time. So what's next in this program? We are going to be broadening our cohort for this research project, kind of our research group, for looking now at 12 months and just more assessments. And also, hopefully, we're going to find some time or a resident to look at specifically with the pharmacist visits to really track all the interventions that we've made along in the last year and a half. And just wanted to give lots of appreciation to all those allowing this massive pharmacy expansion, Carmen, Cameron, and Lana, the pharmacy leadership involved, and of course the physicians, Dr. Kiyashian and Street, who requested and really have supported this process, and our pharmacists that make it all happen, Sandy, Nadia, Kiara, as well as from at the initial point, David, and also pharmacist Brian Herrera for kind of helping to develop.
Oh man.
Right. Thank you so much.
Thank you so much, Marissa. And, thank you so much for the shout out as well. But seriously, you have operationalized this so incredibly well. And hopefully you're going to publish on this because that is some awesome outcomes you all have. So that's awesome to hear. We will have a Q&A session at the end. So I do want to turn it over now to our next innovation presentation, which is implementing and automating pharmacist-led SIBDQ monitoring.
All right, perfect. Hey everyone, my name is Jessica Fan. I'm a clinical pharmacist with Vanderbilt Specialty Pharmacy. At the time of this innovation, I was working full-time in the IBD clinic. Excited to talk to you all today about this with my coworker, Miranda Murray. I'm going to let her introduce herself later on when she gets to her slides. So let's jump into it. We're going to talk about implementing and automating pharmacist-led SIBDQ implementation. So background on this innovation, this was a process standardization to collect, document, and monitor disease severity and response to therapy using the short inflammatory bowel disease questionnaire. So the SIBDQ was integrated within our EHR and it was administered via the patient portal. And then it was implemented to assist with early PA renewal requirements when a new treatment or dose escalation was started, but the patient had not been reevaluated prior to PA expiration. So on the next slide, you'll see this outlines the problem and kind of our processes. But basically, the issue was that we were noticing several patients were needing clinical documentation prior to their new PA renewal. Like we were having a short renewal time frame. There were patients who had a new insurance and we didn't have that clinical documentation available to us. So the first thing that we did is we wanted to do a data pool and see, is this an issue that we think is happening to several patients or is it actually happening a lot? So what we saw with that is we did a 6-month data pool and saw that 86 patients had to have 2 or more PAs within a 3-month time frame. So that kind of validated to us that's a good chunk of patients who we were having to do multiple PAs during that time frame. At the bottom of the figure, you can see the reasons that the patients had to have 2 or more PAs. So for dose escalation, we had 47 patients. For PA reapproval, so those patients who had a really short PA approval time frame, that was 6 patients. And then 31 patients switched insurances. So below those reasons, you'll see the percentage of those patients who had to have disease severity documentation. So we needed that documentation available. It was a high percentage across the board. So that really validated that there was a reason for us to collect this documentation. So as you all know, there's really no standardized questionnaire that everyone is using across the board. We selected SIBDQ. At the time that we were looking at this information, it was actually one of the questionnaires that was sent out to patients prior to all appointments that they had with our IBD providers. Unfortunately, simultaneously, while we were looking through this data, the SIBDQ was removed from the pre-appointment questionnaires. So really that posed us with an issue of being able to have this information at baseline status and then be able to have the information when we needed the clinical documentation for that second PA. So we can go to the next slide. So this is the solution that we came up with. So upon every referral that was received for new therapy or for dose escalation, we were having a baseline SIBDQ gathered for that patient that was automatically sent to the patient via our pre-treatment assessment. We do have another slide we're going to look at a little bit later to look at how that's done. And then we were able to gather 12-week SIBDQ. That's entered manually by the pharmacist at this time. We'll also look into that a little bit later as well. And then we had a 6-month and 12-month manual review. And so we were reassigning that with an EHR report. And this process does repeat with every new therapy or dose escalation referral. So it's done for each of those. Next slide. So for the baseline SIBDQ, every referral that's received within our clinic for a new medication or for a dose escalation, the pharmacist, part of our daily workflow is that we complete a pre-treatment assessment. That's a smart form that's built within our EHR. So that's something that we're already doing. And we were able to integrate this baseline SIBDQ into our smart form. So the pharmacist will review the chart whenever we're filling out the assessment to see if the patient had a baseline SIBDQ on their profile. If they did not have one completed within a 30-day time frame prior to referral, we would then assign an SIBDQ to them. So the middle image here shows the actual, this is just a little snippet from our pre-treatment assessment. So the question asks, SIBDQ completed within 30 days of referral? If you answer no, then it prompts you to be able to select baseline SIBDQ assigned to patient. When you hit yes, that automatically sends the patient the SIBDQ immediately to complete within their patient portal. Next slide. So this is what it's going to look like for the patient. Once they're assigned the SIBDQ, they'll see this within their patient portal under questionnaires. They can just click into that survey, and then it's going to prompt them to fill out the survey. The next slide is going to show us what this looks like for the patient. So it does give them a little bit of background on what exactly is this questionnaire and this survey, and it tells them exactly how to fill it out. So the nice thing about this is a snippet of how the patient is feeling and their symptoms within a 2-week time frame. So they'll be asked questions about their symptoms that they're having as a result of their inflammatory bowel disease. And then that's just a really great way for us to know how they're feeling at that baseline portion or when we send them the renewal assessment. And then this is how we're able to track the SIBDQ. So you can see in the middle, it shows the time frame for when the SIBDQ is completed. So we have one completed on 2/16/26 and 2/26/26 in this specific example. But this is really nice because we're able to see any trends. So is the patient trending one way or another with their SIBDQ responses? Was there a big gap? Was there a big jump in that number? And so it's really nice to be able to have these all in one spot. So we're able to review them and see if this is the normal for the patient or if they're experiencing more symptoms.
Awesome. Thank you, Jessica.
Absolutely. Going to hand it off to Miranda now.
Perfect. So hi, everyone. My name is Miranda Murray. Previously, I did work full-time in our IBD clinic with the Vanderbilt Specialty Pharmacy. Now I'm on our health outcomes and research team, mainly working in patient care improvement, doing quality improvement projects and research projects, really focusing on IBD patients mainly. So now I'm going to shift into talking about our follow-up SIBDQ monitoring process. And the first is with our 12-week follow-up questionnaire. So when a new medication or a new dose is approved, our pharmacists are ordering that medication prescription. They do operate under a collaborative practice agreement. And then they also will order this SIBDQ series, kind of shown here in the image at the bottom. And what this series will do is it will automatically send the SIBDQ to the patient to complete in 12 weeks after the order is placed. So it's not going to send right away, but really kind of 3 months after they're starting this new medication or dose, kind of at that 3-month marker. So hopefully we're seeing some improvement in symptoms by then. Just to give you some background about some SIBDQ by the numbers, we pulled a data report in the past during 2025. We had about 3,000 SIBDQs assigned to patients. Around 1,400 of those were completed for a completion rate of about 48%. And then with those 12-week SIBDQ series, we had around 725 of those series assigned to patients. 222 of those were completed with a 31% completion rate. So obviously would love for our completion rates to be closer to 100%, but for us, we really thought we were satisfied with these numbers, because if we weren't doing this monitoring protocol, we'd be at 0. So we are getting more data, more information from our patients to be able to monitor them better and see how they're doing. Next is the 6 and 12-month follow-up SIBDQ. So we were able to build a report in our medical record. We have Epic that shows patients with their last SIBDQ completed more than 6 months ago. So alerting us that we need to send them another one to complete. And so from there, we can see the patient on the report and send them an on-demand SIBDQ to complete via their patient portal. So the image shows what that smart phrase is, that just kind of giving them some background about why we need them to complete this. And then they'll receive a link to be able to click on and then answer through those 10 questions. So now what I just described with our follow-up SIBDQs, that's still kind of a manual process. And so now what we're moving towards, and what I'm building within our medical record, is to automate these follow-up SIBDQs to our patients. So what we've done is we've built a question, another question into our pre-treatment smart form, asking the pharmacist, do you want to send the patient to follow-up SIBDQ? And we have it kind of in 3 different chunks based on the medication to kind of send at different time frames. So the first is a medication with 3 infusion doses, just 1 infusion dose, or a non-infused medication, or the pharmacist could select if they don't want the patient to receive any follow-up SIBDQs. And then these SIBDQ timeframes are different just because we wanted them to receive their first one 12 weeks after starting their first maintenance dose of medication. So that's why the numbers are a little bit different. Just to highlight our non-infused medication, the first one is kind of similar to the timeframe I just described. They'll receive their first follow-up questionnaire at week 12. And then week 24 is kind of our 6-month marker, and week 48 is around our 12-month marker. This image here is what our practice advisory alerts kind of look like in the medical record for a non-infused medication. So these our practice advisories are going to run in the background. So this alert won't show in practice, but if the patient meets certain criteria, so the pharmacist selected that the patient should receive follow-up SIBDQs, if they have a non-infused prescription on file, and then if a new smart form hasn't been completed, they kind of meet the criteria. And then this SIBDQ will send automatically in the background. It will populate in the patient's chart to complete at that time frame. Now, just want to provide a little case example about what we've done with SIBDQs. So we're asking patients to complete more things. Someone needs to be reviewing it and doing something with. So one project that we did is we looked at having pharmacists to be alerted when the SIBDQ score dropped at least 9 or more points. So that image there shows kind of the in-basket message, what the pharmacist would receive. So here, an example, the patient had a score drop of -16 of 16 points. So from there, the patient can kind of dig into the patient's chart, see what's going on. Did they have a recent medication change? Call them, intervene, see what we need to do. Do we need to do more monitoring, add on additional therapy, something like that? So we found in 65 patients, the SIBDQ score drop alert did lead to 81 different pharmacist actions. Moving forward, we will be alerting the pharmacist of just a total SIBDQ score if it's 45 or less. So that's something that we're going to implement here to really narrow down and focus in on patients that really need more pharmacist attention. So to conclude here, hopefully we've provided you just a use case of what we've done to kind of automate pharmacist monitoring of this SIBDQ. It really has made a positive impact on documentation of clinical response. Really for the authorization renewal process, we've seen it really beneficial. And then integrating SIBDQ administration within the medical record has standardized and streamlined our pharmacist processes and allowed for easier data point tracking within our medical record. So overall, just really recommend working with your health IT department and your analysts and builders, your IBD clinic team. Figure out, what do you want to monitor? What can you monitor? And then what can you automate so that it's really a less manual process for your pharmacy team. It could be with the SABDQ, it could be with something totally different, a homegrown questionnaire like what was just presented. So we appreciate you listening, and I think now we'll move into our Q&A.
Perfect. Thank you so much. And thank you so much for our speakers to kind of really show some of the innovative practice you guys are doing at your institutions, and definitely have a lot of questions. Technically, we have 5 minutes, but I think we might go over just because of the sheer number of questions we have. So just stick with us, everybody. So I first want to start off with Marissa. One of the big questions that kind of came up during this process is specifically related to kind of some of the processes of how you incorporate this. Like, what does the structure of the clinic visit look like? And then are you billing for these visits as well?
We are not billing. That may be part of the patient high satisfaction. It's lots of free attention, but no, we're not currently billing. And then you said how is the build,
like the structure of the visit, in terms of like some of the things you're discussing during that visit, time frame, things like that. I know you mentioned the 30-minute visit, but anything in addition?
Not, I would say kind of one of the bigger changes is we used to incorporate health maintenance with all new medication starts. And then we also had patients just referred for health maintenance. We really had to kind of pull those two apart and just schedule health maintenance a little further down the road for patients. So that was one of the bigger changes for us. So we can really just focus just on the medication at these visits and then at the subsequent follow-ups.
Got it. And then for Miranda and Jessica, one of the questions that specifically comes up, I think one thing that Vanderbilt always does so phenomenally is any kind of interventions or program change you're making are so IT driven to the point where you're able to operationalize scale it, like right at the beginning. This is one of the challenges we've been having at University of Chicago is our process is definitely very manual. It's phone calls, things like that. We've explored thinking about doing MyChart messages, but some of the concerns is just what if something's missed? What do you do when things aren't being kind of answer appropriately, kind of things like that. So I guess one of the questions we had was, what was the largest barrier that you saw in terms of completion rate of that SIBDQ? Because I know you mentioned the completion rate was like 30%, something along those lines, but what were some of the barriers to patients completing that?
Yeah, I think ultimately a majority of our patients are signed up for the My Health at Vanderbilt portal. However, they may not be receiving notifications when a questionnaire is assigned in their chart. So that's one barrier that we see. And so really it does depend when you do that new medication education, kind of alerting them and discussing with them that they will receive these questionnaires. They're going to show in their chart and to please complete them, help motivate them and incentivize them to complete them, describing the reason to them about why we're asking them to complete them.
I just wanted to add one thing. This is something that we've kind of been discussing in our clinic as a whole, not just within VSP, is really how do we capture these patients and have them fill out these questionnaires so that the providers can also utilize these during their visits. And so that's something that's kind of a hot topic all the way around. And so we're working through that as well, ways to talk to patients to make sure that they're filling out these pre-visit questionnaires that are sent out. So it's an issue across the board and not just pharmacy related.
Yeah, I'm actually so glad you brought that up because that was a question I had for Marissa as well, was what percent of your patients are completing that questionnaire before that visit with the pharmacist?
I was almost just going to add on to their statements before you asked me that. That we really try to provide education at that first visit if they had not filled it out about the importance of, oh, the next visit will only be 10 minutes and it's really helpful if you can fill out that in advance. It'll really, kind of help with the efficiency of the visit. Um, the but the information that's captured in that questionnaire is actually so helpful that we're working now to implement it practice wide. So it'll be the exact same survey sent out for physician visits, APP visits. So hopefully it'll just be a standard that the patients know they need to fill out prior to every visit.
Do you know what your percentage completion rate is? Like just ballpark.
No. Ballpark, I would say about 75%. I would say most visits, patients are pretty good, especially once they get the hang of it. Because again, we're seeing them every 2 weeks. And we say, oh, don't forget don't forget to fill this out next time. So we're able to remind them pretty well.
Do you ever see patients getting frustrated or, challenges saying, ah, it's too many questions, like, it's kind of a burden to fill it out, or patients are pretty happy about doing that before?
We tried to keep it as few questions as possible. I haven't had anyone complain about the length of it because ideally it takes them 1 minute unless there's not a lot of free text. It should just be click, click, click all the way down.
Yeah, and that's great to hear because yeah, I know that's something that we are also kind of thinking about as well. Definitely like one of those challenges. How much can we rely on messages to the patients and responses versus just physically calling patients and just getting the answer? I think it's definitely a huge one that we're all learning how to balance. So that's helpful too. Because I think one thing that'd be helpful is to understand like Vanderbilt's approach to the IT side and the implementation side. If people at other institutions wanted to replicate kind of what you did, what are some of the strategies you would recommend for us to build this out on the IT side?
I would definitely recommend if you have a pharmacist champion, anyone that is, trained in pharmacy, specialty pharmacy, to kind of help bridge that gap of that different language that the IT team speaks and the pharmacy team speaks. So I myself I'm a physician builder within Epic, so that's really something that have helped our institution be able to implement IT focused solutions faster for our specialty pharmacy. I understand the pharmacy side and the IT side, so that's really helped us. Highly recommend if you can get any of your pharmacists that are interested in being trained to become a builder within your medical record. I think that would be a great start.
Oh, that's awesome. Was it pretty difficult going through that process?
It's a new world to kind of live in and learn, but I really enjoy it. I think it's very unique to help solve our problems that pharmacists are seeing kind of across specialty pharmacy, and to really help implement something to make their workflow streamlined and more efficient.
Yeah, that's awesome to hear because I do think sometimes that's the biggest challenge is like a lot of times when we want to build a new flow sheet or something like that, it's just putting in a ticket, waiting months, and then you just kind of lose that momentum, I think, in terms of it going. So that's very helpful to know. I do have one last question, and it's kind of a loaded big question for everyone on here. I think sometimes one of the hardest barriers or hesitations in implementing any kind of pharmacist directed monitoring is sometimes a personal one where we don't feel comfortable being able to do this, or we just don't feel like we're in the right place to clinically monitor patients and things like that. I guess one of the questions I have is what was kind of that barrier you faced in terms of doing something along the lines of clinical monitoring, and how would you recommend overcoming that barrier?
Oh, I mean, I guess I'll go first. Honestly, I'm very comfortable with the clinical aspect because I think I've been in this IBD world for 8 years now. It is kind of my world with this clinic. But I mean, time was really the biggest, is finding the time, adjusting our visits, asking leadership for more days, getting approval for more days to be able to provide this comprehensive care. So that would be my comment.
I think for us, one barrier that's still ongoing, because kind of the end of Miranda's portion where she said, we're collecting all of this data for the SIBDQ. Somebody has to be monitoring it and making some decisions when we see a score drop. So that's been a big question for us that's still ongoing because what number does matter? What score drop number matters? What number matters when the patient gets below it? And so that's why we're actually wanting to continue to monitor that and have those pharmacist interventions fire. So we're able to see at what point is it a clinical difference that we're making there. And so I think that was it for us.
All right. So with that, there are a few more questions in the Q&A. If you wouldn't mind just jumping in and maybe just answering some of those questions as well. So thank you so much again for our innovation speakers, just really exciting and I think giving some really cool ideas that we can all bring back to our institutions to help really improve patient outcomes, following patients, kind of things along those lines. So with that being said, I wanted to turn it over to our next speaker who will be talking about pipeline new therapies on the frontier.
All right, good afternoon or good morning, everyone. My name is Shiba Bhatt, and I'm a GI clinical pharmacist at the Cleveland Clinic. I hope that you've been enjoying the symposium thus far, and I appreciate you taking the time to stay for this session. So today I will be discussing the emerging therapies and development in the IBD pipeline. So pipeline discussions can be quite broad, and given that we have limited time here together, my plan is to focus on the most clinically relevant highlights. We're going to first start off by briefly reviewing the key unmet needs in current IBD management, and then from there, I will provide a high-level overview of the evolving treatment landscape, planning with the plan to highlight emerging drug classes, novel mechanisms of actions, and select therapies that are currently in clinical development. So we're going to begin with a brief overview of currently FDA-approved advanced therapies for IBD. And on the slide, you'll see that there's a few available treatment options that are organized by their mechanisms of action, including anti-tumor necrosis factor agents, anti-integrin therapies, interleukin 12, 23, and 23 specific inhibitors, Janus kinase inhibitors, and the S1P receptor modulators. The third column listed here outlines their respective indications, and it's important to note that the medications marked with an asterisk are approved for either ulcerative colitis or Crohn's disease, but not both. So at first glance, it might seem like we have many treatment options, but there's still significant unmet needs. Many patients either don't respond or will lose response over time, and only about 30 to 50% of patients actually achieve durable steroid-free remission. Additionally, current therapies don't adequately address extraintestinal manifestation or reverse structural damage like fibrosis and strictures. We also lack strong tools to guide precision medicine and select the best therapy up front. So there are some ongoing concerns relating around safety, convenience, and administration. And we know that patients prefer safer therapies, they want more oral options and less frequent dosing. Finally, quality of life remains a significant challenge as symptoms such as fatigue, urgency, pain, mental health concerns can often persist. So despite all of the treatment advances that we have so far, there's important gaps that still remain in our current treatment landscape. And before we dive into the pipeline update, I want to briefly review the clinical trial process as all the therapies must progress generally through phase 1 through 3 before reaching the market if the outcomes are favorable. So in phase 1, the drug is tested in a small group, about 20 to 100 healthy volunteers, and the intent of that to assess the safety, the pharmacokinetics and pharmacodynamics, and the initial dosing of that molecule. If the results are favorable here, it can then advance to phase 2, and it's generally studied in about 100 to about 400 patients with the condition to further evaluate efficacy, safety, and dosing. So there's generally some stages within phase 2. So phase 2A specifically tends to focus more on the dose finding and proof of concept. This typically occurs in a smaller group of about 20 to 50 patients, while phase 2B expands to better assess the efficacy at the selected doses and often serve as a smaller version of like a phase 3 trial. If successful, the therapy can then move on to phase 3, and this involves over 1,000 patients generally to confirm the safety and efficacy, often in comparison with or without other treatments. Phase 3A generally tends to provide that pivotal data for the initial approval, and then generally followed by phase 3B post-approval. So main take-home point here is that this is generally a lengthy and rigorous process. It can take up to about 10 to 15 years from initial discovery to potential approval. Now that we've covered some of the foundational concepts, we're going to shift our focus to the pipeline. And for the remainder of this presentation, I'm going to walk through key segments, starting first with a look at how some of our existing mechanisms are actually being reformulated and optimized. So first, I will start off with highlighting icotrokinra, which is the first targeted oral IL-23 inhibitor. And this recently received FDA approval for plaque psoriasis in March 2026. So key data for IBD stems from the Anthem UC trial, and this is currently a phase 2b randomized, double-blind, placebo-controlled, dose-ranging study that included about 252 adults with moderately to severely active ulcerative colitis who have had an inadequate response or intolerance to conventional therapies, biologics including ustekinumab, and small molecules. Patients in the study were randomized to once daily icotrokinra dosing in various doses or placebo, and the primary endpoint was basically clinical response at week 12. So as pictured in the table on the right, you can see that at week 12, all the dosing groups basically achieved statistically significant improvement in clinical response as compared to placebo, and the response rate that we're seeing here ranged about from 55 to 64%. Importantly, the benefits were sustained through week 28, and this includes improvement in clinical remission, endoscopic outcomes, and mucosal healing. From a safety perspective, the results were reassuring. There's been no report of any serious or opportunistic infection, malignancy, thromboembolic event, major cardiovascular event, or death. Currently, icotrokinra is being further evaluated in phase 3 trials for ulcerative colitis, and it's in phase 2b/3 trials for Crohn's disease. So overall, this seems like a promising oral option that targets the IL-23 pathway. So it'll be interesting to see how all of this plays out, because there might be a potential to expand our treatment landscape within IBD. So moving on, the next two agents that we'll cover now will be focusing on ritlecitinib, which is an oral kinase inhibitor. This specifically selectively targets JAK3, so that's a mechanism that we're all familiar with, and it actually has an added mechanism of targeting the TEC family of kinases. Both of these are basically involved in immune signaling. Right now, ritlecitinib is actually FDA approved for severe alopecia areata in patients 12 years and older. Another agent that's also currently in the pipeline is brepocitinib, and this is an oral agent that inhibits specifically JAK1 and TYK2, which again is also involved in the pro-inflammatory cytokine signaling process. This is currently under review actually with the FDA as a new drug application, and it's being potentially evaluated for approval in dermatomyositis. So ritlecitinib and brepocitinib were both evaluated in phase 2A trial in patients with moderate to severe Crohn's disease. The patients have failed at least one prior conventional therapy. And within the Crohn's disease realm, these patients basically had ileocolonic, or colonic disease. And during the induction period, patients received ritlecitinib, brepocitinib, or placebo, followed by a lower dose therapy and a 52-week open label extension. And the primary endpoint of this trial was basically a 50% or greater reduction in the SCSCD scoring at week 12. Both agents were able to demonstrate higher rates of endoscopic response compared to placebo, and there's an observed treatment difference of about 14% for ritlecitinib and about 21% for brepocitinib. From a safety standpoint, adverse events were generally manageable. What they most commonly observed in the trial was primarily COVID-19 infection, headaches, and worsening underlying Crohn's disease. No deaths were reported in this study. So if you look on the right side, this is reports the finding from the ulcerative colitis study, which was also another phase 2b trial. And both of these medicines basically showed dose-dependent improvement in clinical remission at week 8 compared to placebo. Again, similarly, adverse events were mostly mild, and the most common being infection rates were slightly higher than placebo, but there was really no major safety signals identified. There was one death due to myocardial infarction with the ritlecitinib group, and one thromboembolic event seen in the brepocitinib group. However, interestingly, both of these were not considered to be related to the study drug. So next up, we'll be covering Morph 057. This is basically an oral alpha-4 beta-7 integrin inhibitor, and it works by blocking lymphocyte trafficking into the gut, and this basically helps reduce intestinal inflammation. So this is similar in concept to the other integrin targeted therapies, but actually available in an oral formulation. So presently, this agent was evaluated in a phase 2A open-label multi-center study that included a 12-week induction period, followed by a 40 weeks of maintenance. And they had about 35 patients enrolled, with more than about half receiving the 100 milligram twice daily dosing throughout the study. The primary endpoint observed here at week 12 was actually a change in the robust histopathology index. And with MORPH's 057, they did see a mean improvement about 6.4 points, and roughly about 23% of patients achieved histologic remission. Importantly, these improvements, along with pharmacokinetics and pharmacodynamic effects, were maintained through week 52. And ongoing phase 2 studies are continuing to explore MORPH 057, and there's actually combination approaches being studied, particularly with mirikizumab. And so this will be interesting to see how all of this kind of further plays out in the IBD landscape. So it's interesting that we mentioned that MORPH is actually being studied in combination with mirikizumab because it provides a natural transition into combination therapy. And we all know that this is a growing interest in IBD because this approach focuses on targeting multiple mechanisms of action with the potential to hopefully achieve more effective control of inflammation. So first, I will highlight a fixed-dose co-antibody therapy which combine guselkumab, an IL-23 inhibitor, and golimumab, an anti-TNF agent, delivered as a single subcutaneous injection. So in a phase 2A randomized double-blind study in patients with moderately to severely active ulcerative colitis, the combination was compared with each agent alone. And a substantial proportion of patients had prior treatment failure, intolerant, or dependent on immunosuppressants or corticosteroids. So by week 38, combination therapy consistently showed higher rates of key outcomes, including clinical remission, endoscopic improvement, and histologic remission compared with either monotherapy. However, from a safety perspective, infections were the most common serious adverse effects, and there were 2 deaths noted in the trial. So building on these results, there's ongoing phase 2B duet trials in both UC and Crohn's disease are evaluating this approach in a more refractory population. And currently, there's actually some early data that was presented from DDW that showed that there's actually improved clinical and endoscopic outcome with combination therapy, specifically in patients who have had an inadequate response to 2 or more systemic therapies. And in the duet study, so far, the safety findings are generally consistent with the known profiles of what we see with the individual agents alone. So GLP-1 based therapies have generated a lot of significant interest, I think, in the medical world, and the IBD definitely being impacted as well. And there's one emerging approach that combines mirikizumab with tirzepatide, which is a dual GLP-1 GIP agonist that's already approved for several metabolic conditions. So in the clinical trial, particularly phase 3 Commit CD and Commit UC, they're basically assessing that combination to see if whether adding tirzepatide to mirikizumab can improve IBD symptoms while achieving at least a 10% weight loss in patients who are either obese or overweight with comorbidities. And unfortunately, there's no preliminary data to present to you at this time, but I did highlight it because I think that this represents a novel strategy targeting both inflammatory and the metabolic components of the disease. So lastly, the Victriva trial is an ongoing phase 3 study. This actually is evaluating vedolizumab in combination with upadacitinib versus vedolizumab alone. And the focus of the timing of the medication period is actually during the induction, specifically in Crohn's disease. The study is anticipated to be completed in 2028. And the purpose of the study is to determine whether a combination approach can lead to greater reduction in bowel inflammation early in the course of treatment. So while we don't have any preliminary or any findings yet from this trial, I do want to highlight that there's actually some recent data published that actually focused more on ulcerative colitis, and it looked at the same exact combination, and what they found was actually higher clinical and endoscopic remission rates as early as week 8 when compared to vedolizumab monotherapy alone. So overall, these findings suggest that maybe using a stacked or a combination therapy during induction may help achieve faster and more effective disease control in IBD. And so as we look to have more data come out, what basically this might signify is this might shift how we think about early treatment to potentially improve patient outcomes even sooner. So we'll now transition to the next section, which is going to focus on novel mechanisms. So first, starting off with, we're going to first cover obefazimod, which is an investigational once-daily oral small molecule. And this works by enhancing the expression of microRNA 124, which is a natural regulatory of inflammation that helps reduce cytokines and immune cell activity. So obefazimod is actually being currently studied in phase 3 ABTECT-1 and ABTECT-2 trials. Both of these studies are randomized, double-blind, placebo-controlled studies in patients that have moderately to severely active ulcerative colitis, who have had an inadequate response or intolerance to conventional and/or advanced therapies. And one notable strength to highlight of this trial so far is the inclusion of a substantial proportion of patients that have had prior inadequate response, specifically to JAK inhibitors. So in these trials, patients were randomized to receive obefazimod 25 milligram, 50 milligram, or placebo once daily for 8 weeks, and the primary endpoint being clinical remission at week 8 based on a modified Mayo score. So in the phase 3 ABTECT trial, obefazimod 50 milligrams demonstrated significantly higher clinical remission rates at week 8 compared to placebo, and these results were seen consistently across both studies. And importantly, also, all key secondary endpoints, including endoscopic improvement and histologic remission, were also achieved with the 50 milligram dose. The 25 milligram dose actually showed some mixed results, so it met the primary endpoint in one trial, but unfortunately not the other. But overall, obefazimod was well tolerated, and there's no new safety signals identified. There is a 44-week maintenance trial that's ongoing to assess the long-term efficacy and safety, and we're actually hoping that the result is expected sometime in the second quarter of 2026. So hoping that we'll see that potentially soon. Additionally, there is a phase 2b study, which is called the Enhanced CD trial, that's currently underway, particularly in Crohn's disease. So moving on, the next category of medications to highlight here is the bispecific antibodies. These are basically an emerging class of therapy that's designed to target two inflammatory pathways simultaneously within one single molecule. So in IBD, this 2-in-1 approach has the potential to maybe overcome some of the limitations that we see with monotherapy and potentially achieve some deeper, more effective remission without requiring patients to take multiple separate drugs. There's several bispecific antibodies that are currently in development for both Crohn's disease and ulcerative colitis. One example that comes to mind is lutikizumab, which targets a IL-1 alpha and IL-1 beta, and is being studied in phase 2 trials currently. You'll see listed in that first box on the bottom on your left is that there are several other agents in the pipeline targeting various combinations such as TL1A with IL-23, and IL-12/23 with TL1A, and even TNF-alpha with OX40L. So overall, it's kind of looking to be like a promising area. But I do want to highlight that there are some considerations around the type of category of medication. There could be a concern potentially around increased immunogenicity. We don't know necessarily what the long-term safety of the class of medicines may, or the type of medicines may look like. And we're also wondering what the potential degree of immunosuppression may be as well. Overall, I just want to bring this to your attention there because this does remain an important and evolving space and something to kind of continue to watch for as we see the IBD therapeutics unfold. Now I'm gonna spend the bulk of the time likely really on the up and coming medication class that we're hopefully gonna see launch in the IBD space soon. And this is really gonna be around the anti-tumor necrosis factor like ligand 1A or anti-TL1A. So just to give you a little bit of a background, TL1A is a member of the tumor necrosis family, a factor, superfamily, and it basically works by signaling both the death receptor 3 and a decoy receptor. So it represents a more novel mechanism of action as it tends to be a little bit more targeted. TL1A is generally expressed in the endothelial cells and it becomes upregulated in response to inflammatory stimuli. And so highlight that it does have a key role in driving immune cell activation. And what we've seen so far from preclinical and translational studies is that TL1A plays a key role in intestinal inflammation. Well, we've identified that elevated TL1A levels are associated with more severe inflammation, including increased activity of pro-inflammatory T helper cell pathways, specifically T helper cell 17 and 1. And in laboratory models, we find that blocking the TL1A does help reduce these inflammatory signals. Beyond inflammation, that this is where the TL1A is kind of gathering a lot of interest because beyond inflammation, TL1A has also been linked to fibrosis. And overexpression has been shown to promote that fibrotic pathway through immune-mediated mechanism. And what we're finding is that by inhibiting the TL1A binding to the death receptor 3, we can actually reduce both inflammatory response and fibrosis development. So there's currently 3 TL1A inhibitors in phase 3 development, and I'm going to go by them in alphabetical order. So we're going to start off with abemaciclib. So abemaciclib is actually being studied in both ulcerative colitis and Crohn's disease. And the data that we are presenting here comes from the phase 2b Tuscany 2 trial, and this was a randomized, double-blind, placebo-controlled study. It involved 245 patients with moderately to severely active ulcerative colitis, and patients received a subcutaneous dose of afimplabart or placebo every 4 weeks during a 12-week induction period, followed by then maintenance therapy. And what they looked at in terms of outcome was at week 14, the rates of clinical remission as defined by a total Mayo score were basically higher across all of afimplabart dosing groups compared to placebo. And the remission rate that we see here is about in the 20% to about compared to 12 with placebo. So from a safety standpoint, the most common adverse effects that we saw here included primarily nausea, urinary tract infection, worsening ulcerative colitis, anemia, fatigue, and headache. But importantly, no deaths were reported. And as you can see, there's more phase 3 trials ongoing in terms of both the UC and Crohn's at this time. So the next medication I would like to now focus on is duvakitug, which is another TL1A inhibitor that's also progressing through phase 3 development. This one is actually designed to more selectively block TL1A signaling through that DR3 receptor, and so this may potentially help reduce inflammation while preserving some of the key regulatory pathways. So in the phase 2b study, duvakitug was administered as a 2,250 milligram subcutaneous loading dose, followed by a 450 or 900 milligram dose every 2 weeks during the induction. And what we saw from the trial was that there were clinically meaningful efficacy in both Crohn's disease and ulcerative colitis. In Crohn's disease, patients actually achieved higher endoscopic response rates at week 14 compared to placebo, particularly at the higher dose, but there was consistent results across the board regardless of the patient's history of prior treatment exposure. Similarly, in ulcerative colitis, duvakitug produced higher clinical remission rates compared to placebo, and again, there was greater response at higher doses and across both biologic naive and experienced patients. Long-term maintenance data is actually also was recently published, and it had about 130 responders from both ulcerative and Crohn's population. And what we've seen here is that there's actually some durable efficacy with the subcutaneous dosing of 450 or 900 milligram every 4 weeks, with approximately about 40 to 59% of patients maintaining remission or endoscopic response through 44 weeks. So overall, duvakitug has been well tolerated. The most common adverse events that we're seeing reported here is upper respiratory infection, nasopharyngitis, Crohn's disease, and interestingly, hypertension. So lastly, the third TL1A inhibitor in phase 3 development is tulisokibart, which is studied in the phase 2 Artemis UC trial. They had 135 patients with moderately to severely active ulcerative colitis and corticosteroid dependent or failure of conventional or advanced therapies. The patients basically received intravenous tulisokibart 1,000 milligram on day 1, 500 milligrams at week 2, 6, and 10, or they were then randomized to entirely to placebo. And at week 12, what we saw was clinical remission, which is again defined using total Mayo score. And this was achieved in about 26% of patients receiving tulisokibart compared to just 1% on placebo, demonstrating a significant treatment effect. There's more recent maintenance data that was actually presented at DDW as well, and that showed sustained benefit with intravenous tulisokibart 100 milligram or 250 milligram every 4 weeks through week 170, so 170, and there's high rates of symptomatic remission and disease clearance observed through 1 year among the responders. On the Crohn's side, there's phase 2 data from Apollo CD study that showed promising results, with about 26% of patients achieving endoscopic response around at week 12. So overall, tulisokibart, same thing, has demonstrated encouraging efficacy across both UC and Crohn. The most common adverse effects that we're seeing here basically include also COVID-19, urinary tract infection, Crohn's disease, anemia, nasopharyngitis, and fatigue. And there were no treatment-related deaths that occurred in the trial. So precision medicine remains an unmet need in IBD, and one of the things I just want to briefly highlight is that in the Artemis UC trial, they actually tried to incorporate some of these elements through a buccal swab that looked at a genetic biomarker to try to identify patients that are more likely to respond to tulisokibart. Unfortunately, the biomarker positive patients did not actually show any statistically significant improvement in endoscopic outcomes compared to placebo. So that stopped the further testing of this in the trial. However, I do want to acknowledge that there are potential limitations. Though it is like a small sample size, there might have been some potential selection bias. But I just want to recognize that again, that this approach does mark an important step towards advancing precision medicine in IBD. So to finally conclude, I would like to briefly highlight considerations for a pediatric IBD population, along with a few additional emerging therapies in the pipeline. And I think David did a phenomenal job in his pediatric presentation highlighting some of the ongoing clinical trials. So I'm not going to spend too much time here. I just want to highlight that IBD treatment development in pediatric patients has historically been limited by a lot of challenges in the clinical trial design and enrollment. However, I think we're starting to see a shift here. As listed here on the slide, there's many ongoing studies that include pediatric population, some that are even enrolling children as young as 2 years old. So we see here specifically that there's a lot of therapies approved in adult patients that are now actually being studied in the pediatric population. So I'm hoping that this only just reflects the increased momentum to expand treatment options for our younger patients in the near future. And then lastly, though again, pipeline presentations can be very broad. There's many agents that are still in the development across the IBD pipeline that just reflect the rapidly evolving landscape. Overall, I think the strong momentum in the space I'm really hoping will ultimately lead to meaningful improvement in how we can care for our patients with IBD. So thank you for your attention. I'd be happy to take any questions at this time. And I just wanted to highlight this funny comic that I found that says that our trial shows that the new drug performed no better than placebo. And then someone at the table says, oh, maybe we should invest in placebos. Hopefully that's not the case for IBD, but just thought it ended on a funny note. So thank you again. Appreciate the time.
Thank you so much. That was so helpful, I think, to know what drugs are in the pipeline. Because I think as pharmacists, that's one of the key roles we can play is just knowing what's coming, how do we better prepare, just understanding the differences and uptake there as well. So thank you so much, because I feel like that's definitely a very very dense topic, but it was so helpful to see how you had it broken down. Due to time, I'm just gonna ask one question. There are some questions in the Q&A as well. But one of the questions we got was with these newer therapies, combination therapies, and things like that are in the pipeline, do you foresee any current drug classes or existing agents that may just completely fall out of favor and we just won't be utilizing them as much?
Oh, that's a phenomenal question. So no, I don't think that there would be any drug, at least from a mechanism perspective, I don't think that there's going to be any mechanism that's going to necessarily fall out of favor. The one thing I will say that's been of interest is the fact that in our molecule discovery, we're starting to see a little bit more targeted mechanism. So for example, the TL1A kind of a perfect example is in that TNF superfamily, but it's not the same as like the T necrosis factor, but it actually has a little bit of a more targeted mechanism as opposed to TNF being a little bit more broad. So I think the bigger question here will be like, as we start to see, can we get the same efficacy while maintaining a better safety profile? And if we can, then there might be a potential for that other existing mechanism to maybe fall out of play. But I don't think so. I think that like it's interesting to see the uh care of like other autoimmune immunologic conditions, how they kind of just cycle through their meds and we're a little bit more conservative. So yeah, I don't foresee that. Like I think if anything, the landscape is just gonna continue to expand. And it's just gonna hopefully we'll get to a point where if we can offer several mechanisms within one injection, one oral medicine, then I think like we'll hopefully reach that fine point of being able to maximize efficacy, minimize the safety concern, and really get the outcomes that we're hoping for our patients.
Yeah, and that's such a helpful insight to know as well. So really exciting space. I think there's just more therapies in the pipeline as well.